Hello, class. How are you? This is Carrie Ann, your CNA instructor. I'm going to be recording the last three chapters for you all in hopes it make it easier for you for these more in-depth chapters to try and retain the information. It will also make it so hopefully you can go back and see this information. Okay. So, let me stop that recording real quick. I have chapter 25 up. We're going to start at chapter 22. Okay. And then we'll work our way down through the chapters as best we can. All right, everybody. So just let me go ahead and I'll share the slides. Okay. Here we go. All right. Just wait for them to pop up, and there they are. So chapter 22 is the nervous system. As always, we start with terminology. So age-related macular degeneration, also referred to by its abbreviation, AMD, it's a condition in which the macula degenerates, gradually causing central vision loss. Right? If somebody's agitated, this is going to be a state of being excited, restless, or trouble. A lot of nervous system conditions can cause or lead to agitation. We do the agitation as a negative behavior. We can see with dementia sometimes as well. Alzheimer's disease. This is our most well-known form of dementia. It's a progressive, degenerative, incurable disease. We do not know yet what causes it. We do not have a cure. We have certain medications that can slow down its progression right now, but unfortunately, it is incurable. Causes proteins to build up in and around nerve cells, which results in memory loss, cognitive impairment, and behavioral changes. There is some studies being done currently to see if insomnia or lack of sleep could be contributing to the prevalence of Alzheimer's disease, as these buildup of proteins are often cleaned out of our system when we are sleeping. So they're wondering if there might be a correlation, but once again, no definitive conclusions yet what causes it. Bipolar disorder, this is a type of mental health disorder that causes a person to have mood swings and changes in energy level and the ability to function. These are not normal mood swings, these are severe. So usually they go through episodes of depression and then we'll go towards episodes of mania. Episodes of mania are usually severe, heightened euphoric feelings where they feel like there are no negative consequences. So they have very impulsive behavior that can either be sexually, where they start contributing, having intimate relations with multiple partners. It could be going on spending sprees, spending money they don't have. Very, very unhealthy behavior and can lead to a lot of negative consequences in their life. This is bipolar 1. Bipolar type 1 usually is characterized by episodes of depression and mostly that high mania. There's type 2 bipolar disorder. You see more depression and what's called hypomania. So some feelings of euphoria, lack of sleep, heightened drive, if you will, but it's more episodes of depression. And then there's mixed, where it goes back and forth, and even rapid cycle. So your brain, what is your brain? It's a part of your nervous system. It houses in the skull that is responsible for motor activity, memory, thought, speech, and intelligence, along with regulation of vital signs such as heart rate, blood pressure, and breathing. Burnout is very, very important to know as CNAs because healthcare workers deal with burnout very, very often. It's mental or physical exhaustion due to a prolonged period of stress and frustration. This is why I'm constantly reinforcing with you all that you can't pour from an empty cup. So you've got to make sure you take care of yourselves. Take your breaks, eat your food, go to the bathroom when you need to, keep up your water, all right? And take your time off. Take your earned time when you can, okay? Very, very important to prevent burnout that we take care of ourselves. Cataract is a condition in which the lens of the eye becomes cloudy, causing a loss of vision. All right, there is laser treatment that can help correct cataracts. A catastrophic reaction. So this is going to be unreasonable, exaggerated reaction. We see catastrophic reactions in people that have panic disorder, borderline personality disorder, as well as bipolar disorder, where it's this overreaction. In normal, otherwise healthy people, you see it in children, right? A lot of the times they don't get their favorite toy. They'll have this catastrophic reaction of caterwauling and screaming and tantruming and going to the ground. Your central nervous system is the part of your nervous system that is specifically the brain and the spinal cord. Cerebrovascular accident is going to be another name for a stroke, often referred to by its abbreviation CVA. It's a condition caused when the blood supply to the brain is cut off suddenly by a clot. This would be what we would call an ischemic stroke when it's caused by a clot, or a ruptured blood vessel. This would be called a hemorrhagic stroke. Ischemic strokes are going to be a lot easier to treat than hemorrhagic. Ischemic stroke, if it's caused by a clot, if we can get this person to the emergency room and get them that clot busting medication within 4 hours of the onset of symptoms, we can actually reverse most of those symptoms, and they're going to have the greatest possible outcome of reversing them. Hemorrhagic strokes are going to be more difficult, right? Because it's a bleed. We either have to let that bleed end on its own, okay, or we would go in surgically to stop the bleed. Sometimes if the bleed is in an area such as near the brainstem, it's inoperable. Okay, we can't operate on it. Cognition, that's going to be the ability to think clearly, logically. Cognitive behavioral therapy, CBT, very common in people with borderline personality disorder and people that suffer anxiety disorders. It's a type of psychotherapy that is used short term, and it focuses on skills and solutions that a person can use to modify negative thinking and behavior patterns. Okay, so that means we want to head off those catastrophic reactions before they heighten, before we get to that point. So cognitive behavioral therapy will help somebody become aware of when these behaviors might precipitate, when these feelings of either anxiety, panic, agitation start to grow, and cut them off in the head, at the head. Okay, so that can either be reorienting to reality, by naming things around us. This is a light, it has this. You start naming things to kind of reorient you in reality and take you away from that emotional state. And all these different ways somebody can intervene, can kind of calm themselves, they would learn in cognitive behavioral therapy. It's also another psychotherapy we won't talk about, dialectal behavioral therapy. It's the same idea, helping people be more aware of themselves, their behaviors, their emotions, and their triggers, and learning to control it so that they don't have extreme or catastrophic reactions. A concussion is going to be a head injury that occurs from a banging movement of the brain against the skull. The inside of our skull is not perfectly smooth. It's bumpy. It has points. Okay, so when our brain has to bang around in that, we can cause some injury. You can have mild concussions. You can have severe concussions that potentially could cause brain bleeds. So it all depends. And CT scans, X-rays, MRIs can help show those. A delusion is going to be a belief in something that is not true or is out of touch with reality. So if I said to you, I am the second coming of Jesus Christ, okay, this would be a delusion. We see delusions often as a hallmark of schizophrenia, okay, where they have delusions, hallucinations. Dementia is our umbrella term, okay? Many different forms of dementia you learned about in your dementia training, but it's a serious progressive loss of mental abilities, such as thinking, remembering, reasoning, and communicating. A disruptive behavior is any behavior that disrupts others. So if you're yelling, if you're catastrophic reaction, crying uncontrollably, these can be disruptive behaviors, okay? They're also going to interfere with your activities of daily living. To elope is to escape. So specifically in medicine, we use this often with our dementia patients, Alzheimer patients. We'll do an elopement risk. We want to know what is the probability of them trying to wander away from a protected area or leave the unit. What we can do if they have a high elopement risk is we can suggest the locked dementia unit, right? Those doors are locked. They can't wander away. They can't get out. Epilepsy is going to be a disorder that causes reoccurring seizures. Farsightedness. Farsightedness actually means I can see objects in the distance better than I can see up close. So farsighted individuals usually have what's called reading glasses. Another term for it is hyperopia. Glaucoma is going to be another eye condition. It's a condition in which the pressure in the eye increases, and it actually can cause damage to the optic nerve and can lead to blindness. An hallucination is going to be a delusion, but not just a thought. It uses our senses. So we're going to see, hear, smell, taste, or feel things that are not actually there. A hearing aid is going to be a small device we place in the ear. Usually it goes right into the ear canal, and the battery pack loops around the back of the ear, though they can come in different ways and are very, very common in long-term care. Hemianopsia. Hemianopsia is going to be a loss of vision on one half of the visual field. This often occurs due to a stroke, CVA, a tumor, or even trauma. Hoarding, that's going to be collecting and put away things in a guarded way. We want to be wary of hoarding when it's unhealthy. If we're hoarding things that can potentially be fire hazards, if these individuals are on oxygen, such as a lot of paper, books, clutter, okay, but also people can hoard things that, are just waste. For instance, I had a patient once hoard chicken carcasses. Her son would come in with rotisserie chickens, and then before he would get a chance to throw it away, she would actually store it. So decomposing food matter is definitely something we want to prevent with hoarding. So sometimes with these individuals, when they move in, if they were hoarding at home, you have to check their drawers, their supplies, and you'll notice they start to build things up. They're going to try and keep them in a guarded way. Hoarding is a reaction usually to trauma, to loss. So they need a lot of guidance, psychotherapy to help with that. But our jobs, especially in long-term care, is keeping them safe and healthy. An intervention is going to be a way to improve or change an action or a development. As nurses, everybody that comes into our facility, we have to do a care plan. All care plans have to have a problem or a diagnosis to explain and support why we need skilled nursing care. Under those, we have to write interventions. These are what we're going to do to address these problems. This is the skilled nursing care we're going to give. All right. And these can be relayed to you all as CNAs so that you know ways to help and intervene appropriately with these residents. To be irreversible is to not return to its original state. Okay, so it cannot go back. Major depressive disorder, often referred to by its abbreviation MDD, is going to be a type of mental health disorder that causes social withdrawal, lack of energy, and apathy. Among other symptoms, it can also be called clinical depression. Just like we don't tell somebody who has a broken leg to, just walk it off, you'll get over it, right? We're not going to tell somebody with major depressive disorder to just get over it. It's a clinical diagnosis that's going to require psychotherapy medication, okay? Often cause either trauma that happened in their life or chemical imbalance in their brain. So it's not something someone can just get over. So we always want to make sure we come take care of these individuals with a level of empathy and understanding and compassion. Meniere's disease, it is a disorder of the inner ear caused by a buildup of fluid, and it eventually leads to vertigo or dizziness, and even tinnitus. You can have ringing in the ear, as well as pain or pressure. Mental health is the normal function of emotional and intellectual abilities. Mental health disorders, it is a disease that disrupts a person's ability to function at a normal level in their family, home, or community, often causes inappropriate behavior. All right, so if we have a mental health disorder, usually it's interfering with our activities of daily life, and that's why these individuals seek medical intervention and support. MS, multiple sclerosis, it's a progressive disease in which the protective covering of the nerve, spinal cord, and white matter of the brain break down over time, causes problems with balance, walking, and many other symptoms. Once again, it's a progressive disease. It's incurable, okay? It slowly gets worse and can lead to hemiplegia, which is not being able to feel anything from the waist down, and even quadriplegia, not being able to move or feel anything from the neck down. And of course, as it progresses, these individuals are going to need a higher acuity of care. Nearsightedness, so that means I can see things closer to me, but not farther away, also called myopia. All right, that's why I have glasses. I can't see distances. So if I took off my glasses, it's going to be from right here on that I actually have blurred vision. So I have to wear my glasses all the time. And it is on my driver's license that I require glasses or contacts. A neuron is your basic nerve cell of the nervous system. OCD, or obsessive compulsive disorder. This is a type of mental health disorder characterized by intrusive, repetitive thoughts or behaviors that cause anxiety or stress. All right. OCD isn't just, oh, I really need something. It's a compulsion. It can get exacerbated during times of stress. So say somebody's OCD is they need to wash their hand and then they just lost their child, lost their husband. Now they're going to have to wash their hands 10 times in a row. I've seen people with this compulsion that will actually wash their hands raw. Okay. Once again, will require psychiatric intervention to help treat the symptoms of that. Otitis media is just another name for a middle ear infection. Symptoms are going to be pain, pressure, fever, as well as you can have a reduced ability to hear. Pacing, so that's walking back and forth in the same area. If we have a resident and they're stable, okay, so they're not a fall risk, they walk pretty well, and pacing is a symptom or a consequence of their illness, such as Alzheimer's disease, a form of dementia, you still want to allow the pacing if you can, as long as it's not bothering anybody and they're in a safe area, okay? Even a locked dementia unit or somewhere they can't elope from. So a panic disorder is a type of mental health disorder characterized by panic attacks. So these are repeated episodes of intense fear. They don't come from a place of rationality, okay? People can even wake up with panic disorders that have severe anxiety disorders, okay? Physical symptoms they can get: rapid heartbeat, dizziness, chest pain, shortness of breath, an upset stomach, nausea. I've even heard of cases where it was such a severe panic attack, they actually got numbness and tingling starting from their fingertips, radiating up their arms. A lot of times back in the day, if you saw somebody having a panic attack, that old trick of breathing into a paper bag, that idea was the reuptake of carbon dioxide into our system can actually help calm, okay, that fight or flight response somebody's having with the panic disorder. Paraplegia, so plegia, loss of function, okay, para, so that's two limbs. So paraplegia is usually the loss of the lower half of the body or the waist down. Parkinson's disease is a progressive disease that causes a portion of the brain to degenerate, causes rigid muscles, shuffling gait, pill rolling, mask-like face, and the tall tale tremors. Usually our route for treatment when it comes to Parkinson's is a medication called levodopa, carbidopa-levodopa, all right, otherwise known as Sinemet. Fortunately, the medication was originally made to take over long duration, so it can actually cause increased confusion. But the problem is, what do? Are we more worried about increased confusion, or are we more worried about the tremors and rigid muscles? So sometimes you have to balance out the pros and cons of that medication. And once again, it's progressive, it's incurable. Someone with Parkinson's will eventually pass away from the disease. Your peripheral nervous system is a part of your nervous system made up of nerves that extend throughout your body, and it connects to your spinal cord. So we said our central nervous system is the brain and the spinal cord. Peripheral nervous system is all the nerves that come out from our spinal cord. Perseveration is going to be the repetition of words, phrases, questions, or actions. We see perseveration in cases of severe mental illness, as well as we see that sometimes in the development of dementia, where they'll forget they say a word or a question and they'll keep repeating it. A phobia is going to be an intense, irrational fear or anxiety about an object, place, or situation. Okay, so it's going to be extreme. It's going to be intense. So some people say, oh, I have a phobia of a spider. So if I see a spider, I make my husband kill it. No, that's not a phobia. If somebody had a phobia of spiders and they walked in their house and they saw one, they would probably have a catastrophic reaction. Crying, screaming, running out of the house, refusing to come back into the house, thinking for the next week that they see a spider everywhere. So it's an intense, irrational fear that can also interfere with activities of daily living. A lot of times phobias as well, going to need psychotherapy. A lot of times what they'll do is something called exposure therapy. So slowly exposing the person to whatever their phobia is to kind of decondition their body to have these extreme reactions. PTSD, post-traumatic stress disorder. This is a type of mental health disorder caused by witnessing or experiencing a traumatic event. So we see PTSD very often in our veterans, individuals that have been through war, also individuals that have survived catastrophic weather things such as tsunamis, hurricanes, you can get it. As well, survivors of domestic abuse can have PTSD. Rape victims can have PTSD. All right. And what ends up happening is their brain rewires itself and they get something called triggers. So anything that reminds them of that traumatic event can actually cause them to have a flashback where they start to go back into that event and live it again. They can even have nightmares where they relive this traumatic event again and they don't get very good sleep. It's actually a blood pressure medication, Prazozin, P-R-O-S, O-Z-I-N, Prazozin. It's a blood pressure medication, but they found that in very small doses when we give it to people with PTSD at night can actually keep the PTSD nightmares away. Presbyopia is an age-related condition in which the eyes cannot focus clearly on objects that are near, and close-up vision becomes blurry. So if something's progressive, like a lot of the illnesses and diseases we're talking about, it gets worse, it deteriorates, okay? There's no cure. Psychotherapy is going to be a method of treating mental health disorders that involves talking about one's problems with mental health professionals. So be that counselors, psychiatrists, okay? Regular meetings and keeping up with them and keeping up with psychiatric medications is going to be key in stabilizing the conditions. Quadriplegia, so quad for plegia, loss of function. So this is going to be when you have a loss of function of all your limbs, usually from the neck down. So that's going to be legs, trunks, and arms. Reminiscence therapy, we see this often in people with dementia or Alzheimer's, locked dementia units, usually activities all day long to try and engage people. Reminiscence is going to be a good one because it helps remind people and talk about the past. It's kind of been proven with dementia. You use your short-term memory first, right? So reminiscent therapy helps to keep those connections to our longer-lasting memory. When you're rummaging, you're going through items that belong to other people. You can also rummage through your own items, right? Schizophrenia. So this is a type of mental health disorder that may involve acute episodes. It affects a person's ability to think, communicate, make decisions, and even understand reality. I said the hallmark of schizophrenia often is delusions and hallucinations. It's often very prevalent in a certain demographic of individuals. We find that women in their mid to late 20s who have had no signs and symptoms their whole life can develop schizophrenia at that age. Seasonal affective disorder, SAD, is a type of depression, but it only comes out during the cold months, so every fall and winter. Characterized by low energy, low interest in activities, sleeping more than usual, overeating or even undereating, weight gain, weight loss, sadness, and withdrawal. But once again, once that sun comes out again, weather gets better, it tends to go away. It's just in the colder months. Social anxiety disorder definitely became more prevalent during the pandemic, right? When people weren't going out as much, kind of reinforced this phobia. It's a type of mental health disorder characterized by excessive anxiety about social situations, otherwise known as social phobia. Your spinal cord is a part of your nervous system inside the vertebral canal that conducts messages between the brain and the body, and it also controls spinal reflexes. Substance abuse. This is the repeated use of legal and illegal substances in a way that is harmful to oneself or others. So it isn't just illegal like heroin, cocaine, also can be legal ones. Alcohol, tobacco, caffeine, okay, can all be substances that are abused. I remember back when I was in high school, I remember there was a thing about cough syrup, Robitussin. Children were going to CVS and whatnot and purchasing cough syrup and drinking it in high quantities to get a high out of it. And then I remember it was locked up behind the counter and you had to ask for permission, and there was a limit on how many you could buy because of the prevalence of abuse of it. So sundowning, this is a condition we see a lot in our dementia patients. When a person becomes restless and agitated, specifically in late afternoon, evening, or night. I always tell my CNAs, your residents tend to present differently depending on what type of day it is. Who they are during the day might not be who they are in the evening, might not be who they are overnight, right? And that's usually due to sundowning. Sundowning is the also reason why we often give showers in the morning versus at night, because we're trying to circumvent these behaviors that can pop up. So a trigger, I already kind of talked about specifically with PTSD. It's a situation that leads to agitation. So for instance, say I have PTSD because I'm a veteran, I went to war. Maybe hearing a loud noise that sounds like a gunshot can lead to a trigger, a flashback of my trauma. So when we validate someone, we're giving value to or approving. A lot of times when family residents come to you and they're upset about something, they just want validation. They want you to acknowledge their feelings and let them know, yes, they're warranted in the situation that they feel them in. Validation therapy is actually a type of therapy that lets people with Alzheimer's disease believe they're living in the past or in imaginary circumstances. One thing I always want to reinforce, we never try and pull a dementia person into our reality. If somebody forgot that their husband passed away 20 years ago, we don't want to remind them every single day and have to relive that death every single day, right? We're going to go with them where they are in their life. If the husband's at work and they're still caring for their 2 adult children who they think in their mind are still 2 and 3, you go with that. You use little white lies. You use positivity and redirection. Violence is going to be forceful actions that include attacking, hitting, or threatening someone. Wandering, that's walking aimlessly around the facility or the facility grounds. Like I said, wandering isn't something that we necessarily need to prevent as long as they're not a fall risk, okay? They have a stable gait or walk to them. They're ambulating well. We can allow wandering as long as it's within a safe area that they're not going to elope or get hurt in. So this is a very basic image of your nervous system. What's in red is your central nervous system, which is your spine and your brain, okay? Your peripheral nervous system is all there in blue. And as you can see, it goes throughout your whole body. So depending on where you receive trauma along your spine is what's going to affect all the nerves below it. So as you can see, if somebody became a quadriplegic from a diving accident, then there might have been an injury right along here, their neck, because they no longer can sense or move their limbs below that. If somebody suffers from hemiplegia, they might have sustained an injury to their mid-back right around here, because then it's going to be all the nerves below that would be affected. Okay. The brain controls speech, motor, and sensory activity, intelligence, memory, reasoning, coordination, reflexes, breathing, emotions, and heart rate. Also controls certain glands, such as your adrenal glands, your fight or flight response. The brain can actually stimulate hormones that stimulate other hormones, okay? There's a lot to the endocrine system, right? But we're still in the nervous system. The spinal cord conducts messages between the brain and the body within its pathways. The brain specifically consists of the cerebellum, and brainstem. When it comes to our peripheral nervous system, it consists of the cranial and spinal nerves. Nerves carry messages to and from the brain. The somatic nervous system helps with conscious movement of the skeletal system. 2 parts of the autonomic nervous system regulate body functions and activate aid in recovery from the body's fight or flight response. Okay. And it's important to also note when we talk about the nervous system, we also want to talk about our sense organs. So that's skin, tongue, nose, eyes, and ears. Okay. We also receive impulses from our environment and we relay these impulses to our brain. So this is an image of your eye. The sclera is going to be the whites of your eye. The cornea is the transparent front part. Okay, that's right here. Okay, your iris is the part of your eye that gives its genetic color. Your pupil, okay, is a circular opening in the center of the eye, controls how much light, okay, comes into the eye. It dilates, open, or constricts or closes. All right. Once we take an image, we take that image to the back of our retina, which is located inside the back of the eye. It contains cells that respond to light, and then it's going to take that message and send it along the optic nerve to the brain. This is a picture of your ear. You have your outer ear, also sometimes called the pinna. It collects sound waves and it directs them inwards through the external auditory canal towards the middle ear. The middle ear amplifies and transfers sound waves to the inner ear. The inner ear contains tiny hair cells which send nerve impulses to the brain. You have your eardrum, okay, which is right here at the base of the auditory canal. It separates the outer ear from the middle ear, also known as the tympanic membrane. It's why we don't want to push ear swabs, cotton swabs, deep into our ear canal. We can actually cause a backup of earwax down in our ear canal. And worst case, if you push it too far in, you can actually perforate your eardrum. And then the ossicles. Ossicles are in the middle ear. They're 3 tiny bones which pick up vibrations and send impulses to the brain. So what are the functions of the nervous system? It controls and coordinates mental processes and voluntary movements, provides reflex centers of heartbeat and respiration, senses and responses to changes occurring both inside and outside the body. So normal changes of aging. Once again, our body is a machine, still going to work, just won't work as well. Responses and reflexes slow as we age. Some memory loss occurs, especially our short-term memory. Long-term memory tends to be last to go. That's why reminiscent therapy can be so helpful with people with dementia. Sensitivity of nerve endings and skin decreases, resulting in diminished sense of touch. And some hearing loss occurs. Senses of vision, smell, and taste weaken. Even our receptors to hot and cold can decrease. So there's difference between a primary and a secondary headache. Primary headache are not caused by any underlying condition. Secondary headaches are caused by a condition such as an aneurysm or a tumor. There's some type of primary headaches like migraines that may have genetic link. Symptoms specifically of a migraine are going to be severe pain, often on one side of the head. You can have nausea, vomiting, sensitivity to light and/or sound. Visual warnings sometimes, an aura may precede the headache or occur on their own. Okay. And these are a little different than cluster headaches. Cluster headaches are severe pain, especially behind or around one eye or one side of the head, nasal stuffiness, and then you can sometimes have drooping or swelling around one eye may occur. Okay. Both cluster headaches and migraines may be triggered by certain foods or beverages. And treatment's going to be medication, sometimes including oxygen for cluster headaches, and avoidance of triggers. So, what are the difference between ischemic stroke, hemorrhagic stroke, and transient ischemic attack? Okay. Once again, these are all going to be types of cerebrovascular accidents, CVAs. Okay. An ischemic stroke is going to be caused by an obstruction inside a blood vessel. Okay. It's the most common type. Okay. We worry about the blood supply being blocked and brain cells beginning to die. Once again, we can prevent these symptoms and they have a good trajectory or outlook if we get them treatment within 4 hours of onset of symptoms. All right. Hemorrhagic stroke isn't as good, not as well known. It's leaking or rupturing of a blood vessel inside the brain. Once again, we're either going to have to, if it's a minimal bleed, let it resolve on its own or potentially operate if possible, depending on where that bleed is. Okay. Transient ischemic attack, TIA, is also referred to as a mini stroke, and it's a warning sign that strokes are coming. Very similar symptoms of other strokes, but they completely reverse, usually within sometimes minutes. Okay. And symptoms are also going to differ depending on which side of the brain has been affected. Okay. So Parkinson's disease is a progressive disease. What does that mean? Okay, it means that part of the brain is going to degenerate and that it's incurable and that it's going to keep progressing until the day they pass. It's caused by neurons in the brain that produce dopamine begin to break down and die. Once again, symptoms are going to be tremors or shaking, mask-like face, they get very apathetic features, pill rolling, rigid muscles, shuffling gait, slurred speech, mood swings, and can even have gradual behavior changes. Treatment, once again, drug therapy, Sinemet, that carbidopa levodopa drug I was talking about, and could even include surgery. So true or false? A concussion often causes paraplegia or quadriplegia. The answer to that is going to be false, okay? Like I showed you on the diagram, depending on where the spinal cord injury is what's going to cause paraplegia or quadriplegia, all right? We often see this spinal cord injuries, car accidents, or swimming or diving accidents. So we're going to use some key terms in this learning objective to finish the sentence. Possible causes of seizure include tremors, tumors, head injuries, medication, high fevers, and blank. This is a disorder that causes reoccurring seizures. So a condition or a disorder that causes reoccurring seizures is known as epilepsy. Epilepsy. So remember, vision changes affect people of all ages. Both nearsightedness, myopia, and farsightedness, hyperopia, are usually treated with eyeglasses, contact lenses, or even surgery, LASIK. LASIK surgery can actually make it so you don't need glasses or contacts anymore. But there is specific guidelines or criteria you have to meet. And unfortunately, I've never been able to meet it. I have to have a stable prescription. So my eyes can change in 3 years for me to be considered for LASIK. So unfortunately, my eyes just get a little worse every year. But I have a stepmother who had the surgery, loved it. No longer has to have glasses. So true or false? Diabetes is a possible cause of cataract. Now, I've surprised a lot of my students with this answer before, but it's actually true. It's true, okay? Cataracts develop when the lens of the eye becomes cloudy, and its causes can be diabetes. Diabetes affects a lot of our main organs, our sensory organs, and our circulation, as we'll get into with our endocrine, all right? Can also be caused by eye injury, can be inherited, or result from normal aging. Symptoms are going to be blurred vision, a glare when driving at night, yellowing of vision, and treatment is going to be surgery. So there are 2 forms of age-related macular degeneration. These are going to be wet and dry AMD. Okay, dry is more common. So important to note about this, it's a condition in which part of the retina degenerates. Risk factors are going to include aging, smoking, sun exposure, hereditary, gender, and race. Treatment's going to involve laser surgery, injections, zinc, and antioxidants. Residents may have different levels of vision impairments. Okay, so things that we can do to help someone with a visual impairment. We want to encourage the use of eyeglasses or contact lenses if worn. We want to keep eyeglasses clean and safe. Okay, if you want to see the procedure for caring for eyeglasses, it's on page 416 of your textbook. We want to change cases for contact lenses regularly. Always want to identify yourself as you enter the room. Once again, they can't see you, right? So you want to make sure you're using your voice to explain who you are, when you're walking in, what you're doing, when you touch something. Got to keep the doors completely open or closed. Halfway can cause confusion. People can bang into it. Same with why we leave furniture in place. People that have vision impairment get used to where things are, know how to move around it. So if you move something of theirs, it could become a tripping hazard. All right. You can use the face of an imaginary clock to explain the position of objects in a room or where food is on their food tray. Your chicken's at 12, your mashed potatoes at 3, your peas are at 6, and your roll is at 9. Okay. When we walk with someone with a visual impairment, we're going to walk to the side, but a little ahead of them. Okay. We might hold their arm. We want to walk at their pace. We can assist these residents with completing their menu and set up their meal trays as needed. They like to read and they still have a little bit of vision. Maybe we can get them large print books or audio books, digital books. We could read to the resident if they can desire. And we can also assist the doctor with vision screening if we needed to. So now we're going to use learning from this objective to finish this sentence. An artificial eye is a type of prosthetic, right? It's a type of prosthetic, but it does not provide vision, okay? So an artificial eye is going to be a prosthetic that doesn't function, okay? It's just more for aesthetic look reasons. It's necessary for people who've lost an eye to cancer, other disease, or injury. Most are made of plastic. You get them made of glass as well. They're held in place by suction. It's very careful. You got to be very careful to follow the care instructions. Do not want to use alcohol or anything abrasive to clean that eye. Always want to act professionally during care. Keep the eye covered completely in solution when stored. So otitis media is a medical term for what common condition? Okay. If you remember, otitis media is just a fancy word for ear infection, specifically an infection in the middle ear. Symptoms can include pain, pressure, fever, and a reduced ability to hear. Treatment is mostly antibiotics. So what should we do before we insert a hearing aid? Okay. We always want to turn the volume down, right? We don't want to blast somebody's eardrum, okay? Also want to make sure that we don't get it exposed to any water. So we got to take it out before bathing, showering, or shampooing somebody's hair. We always want to be careful when handling hearing aids. They're very, very expensive. They also get lost very easily. So always check food trays, check sheets when you're changing bed linen because they can get lost in there. You want to turn them off when they're not in use. So I usually take the battery out, okay, so that it doesn't drain. You want to replace the batteries if needed. And a lot of times the nurses will have extra batteries at the nurse's station or even in their medication carts. Never want to submerge it in water. Do not want hair care products to get sprayed on it. It could break them. You want to check hearing aids before removing bed linen and meal trays once again, and report any signs of sores or abrasions on the ear as well as wax buildup. Somebody's having wax buildup, so their hearing aid isn't working as great. They need to get their ear flushed out. I can get an order from the physician for Deprox drops. These are a type of drops that soften the wax. We put a few drops in the ear every night for usually 3 consecutive days. Then on the 4th day, once it's softened the earwax enough, I can go in with the syringe and water and flush out that ear. Deprox drops you can also buy over the counter if it's something you wanted to do on your own, and you could flush your ear out in the shower. So remember, dementia is not a normal part of aging. It's not. It's common, but it's not normal. All right, and possible causes, we talked about these different diseases: Alzheimer's disease, vascular dementia, Lewy body dementia, Parkinson's can cause dementia, AIDS, Huntington's, excessive alcohol or drug use, head injury, thyroid disorders, and nutritional deficiencies can all cause dementia, unfortunately. So we're going to use some key terms from the learning objective to finish these sentences. People who have blank have reduced blank. Some forms can be treated, but many are blank. All right. So we're going to talk about what we already run over. So it's people who have dementia, have reduced cognition. Some forms can be treated, but many are irreversible. Okay. They're progressive. They're irreversible. There is no, unfortunately, cure for them. Okay. So what do we know about Alzheimer's disease? That it's progressive. It's irreversible. Okay. It occurs when tangled nerve fibers and protein deposits form in the brain that we talked about, usually cleared when we're sleeping. Cause, unfortunately, though, is still unknown. Older skills, longer memory are usually kept longer. Okay, older memory is usually kept longer. There's different stages to Alzheimer's disease as defined by the Alzheimer's Association. So early stage or mild Alzheimer's, the person may show some memory loss and forgetting some words and location of familiar objects. Medical examination may show problems with memory and concentration, and the person may still be independent and able to work, drive, and do other activities. When we get into middle stage or moderate Alzheimer's disease, this is usually the stage that generally lasts the longest. People may forget recent events, maybe some of their own past experiences and background. People may demonstrate some changes in personality and may be moody or withdrawn. People will start to need help with activities of daily living, such as choosing clothing appropriately and knowing the order in which it goes on. Sleep patterns may change, so our circadian rhythm becomes affected. Confusion about time and place may occur. Late stage or severe Alzheimer's is the final stage. People may be unable to communicate with others, control movement, or respond to their surroundings. They're going to need significant help with their ADLs, including eating and toileting. And the ability to walk, sit, and swallow can all be affected. So remember, working, socializing, reading, problem solving, and exercising should all be encouraged with our residents with AD, Alzheimer's disease. Having residents do as much as possible for themselves may even help slow the progression of the disease, right? So you use it or you lose it, okay? So these attitudes are helpful when caring for residents with Alzheimer's disease. Don't take it personally, right? This is the progression of the disease, okay? It affects your behavior, so don't take it personally. Be empathetic. Look at what life is like through their eyes. Work with the symptoms and behaviors noted. Work as a team. Be aware of the difficulties associated with caregiving. Work with the family members and remember the goals of the care plan. So it's always important to note that burnout is very, very common among caregivers of residents with Alzheimer's disease. Okay, so always want to take care of yourself. Drink, eat, take your breaks, and take your time off. Okay, you need it to help balance that, to recharge yourself, and you'll be a better caregiver for it. Is early evening likely to be a good time to bathe a resident with Alzheimer's disease? Probably not, right? Because we talked about sundowning. Sundowning tends to happen in early evening where they can become more agitated, right? So to make bathing easier for our residents, we want to schedule bathing when the resident is least agitated. Want to be organized. Prepare the resident before bathing. Walk with a resident down to the hall, stopping at the tub room. Make sure the bathroom's well lit. Provide privacy. Be calm and quiet. Keep the process simple. Offer the resident a washcloth to hold. Ensure safety. Do not try to force the resident to bathe, right? Residents' rights, they can still refuse. We always want to encourage. Maybe ask another person to try and convince them, but a no is a no. Right? Allow residents to enjoy the bath. Be encouraging, be positive, and once again, if somebody's taking a bath, it's the best time to observe their skin. How can nursing assistants support the physical and mental emotional health of residents with Alzheimer's disease? Okay, so for physical health, we always want to what? Infection prevention, right? So follow your standard precautions. Help residents wash their hands. Report potential problems. Ensure safety to reduce the risk of falls. Provide excellent skin care. And watch for and report any signs of pain or fluctuation in their vital signs. For mental and emotional health, we want to maintain self-esteem, encourage independence wherever you can, share enjoyable activities, and you want to reward positive and independent behavior with smiles and warm touches. So remember, a resident with Alzheimer's disease who wanders away from a protected area and does not return has what we call eloped. This can be a very dangerous situation for the resident. We want to report elopement right away, keep doors locked when leaving an Alzheimer's unit or area. If it is a code, do not give the code away, all right? Don't give it to family members, and be aware who's around you. I've had residents, family members come up behind me and watch me and try and steal the number, okay? And once again, we do have an elopement risk assessment that nursing does to kind of gander where somebody is with their potential for elopement. And there are some facilities, this would be considered a restraint, so would need a doctor's order, but have elopement bans, which will actually go off if they leave the facility or leave the unit. So why can caring for someone with Alzheimer's disease be very difficult, right? It can be those behaviors, that resistance, that change in personality, the acceptance of that new personality, the combativeness, a lot of frustrating behaviors. So nursing assistants must never abuse residents in any way. If you feel you cannot respond professionally to a resident, talk to your supervisor, okay? Take a break off the floor if you need to, if it's getting frustrated, but try not to take it personally. So meaningful activities you can do with your Alzheimer's patients. Help them draw, okay, or improve their abilities, okay? Maybe they were a tinker. They like to tinker with things. Maybe getting them laces they can practice tying, or little latches. I've given some of my more advanced individuals, what is it called? Busy boards. You see them for toddlers, have all these little activities and things that you can work with. Sometimes they just want a load of towels. You can get them to fold towels. If they worked in administration, maybe paperwork, have them organize, file paperwork. Okay. So keeping them busy, keeping them doing stuff. And note that some of these activities that I mentioned might only keep them distracted 20, 30 minutes before they get up and start wandering again, all right? So sometimes you got to switch off a lot. But as long as it's entertaining them and you're finding some little things and engaging them when you can, you're doing your job. So remember, nursing assistants can gather information from residents' friends and family. So if they've advanced enough in their dementia they can't tell you, talk to their family about their likes, their dislikes, their interests. This will give you an idea of what activities you can give them. Okay, I can give you an example. I took care of a gentleman. We didn't know what he was into. He kept wandering. We couldn't get him to sit down, engage anything. Found out from the wife he loved golf. We bought a little putting green, and he would sit there for hours and just boop, putt that ball. And it made him happy, and it kept up some of his physical motor skills, right? And I'm going to just pop over some of the situational questions because I just want to make sure you guys get the bread and butter of these chapters. Once again, these chapters are more like 101 nursing than they are CNA course, so don't feel too overwhelmed with them if you can, okay? Situational questions when it pertains to systems, you're going to be going in depth if you move on to nursing school, but I'm not going to go too much for CNA, all right? So remember, mentally healthy person has successful relationships with family, friends, neighbors, and coworkers. They will perform well in professional and home settings and will meet their responsibilities. All right, so it's important to note mental health disorder affect a person's ability to function with their family, with their home, work, or their community. Okay, they can cause inappropriate behavior, so they affect their ability to function in everyday life. Anxiety disorders are going to include generalized anxiety disorder, panic disorder, and social anxiety disorder. Effective treatment is going to be psychotherapy, as well as they might need some anti-anxieties medications. Cognitive behavioral therapy, CBT, can also be helpful to head off those panic attacks before they heighten. So remember, a phobia is going to be an intense irrational fear or anxiety about an object, place, or situation. A person with social anxiety disorder has a phobia of social situations. That's an example. And like I said, we saw it a lot more after the pandemic, right? Because people that already had a little bit of anxiety in social situations now weren't getting exposed to social situations at all. So it's going to make it worse. So we said obsessive compulsive disorder, OCD, is characterized by intrusive, repetitive thoughts or behaviors. Treatment is going to be medication and psychotherapy. We said PTSD, post-traumatic stress disorder, may develop after a traumatic experience, a crime, a disaster, or an accident. Symptoms include flashbacks. So when they get those triggers, sometimes it goes into a flashback. They can have withdrawal and they can have sleep disturbances. Treatment's going to be medication and psychotherapy. Okay. So what do we know about MDD? Major depressive disorder, right? It's a serious mental health disorder in which overwhelming sadness makes it difficult for a person to function normally. Symptoms include pain, fatigue, apathy, weight loss or gain, sleep problems, insomnia, irritability, feelings of worthlessness, depression cannot be cured through sheer will. Just like we don't tell anybody with a broken leg to walk it off, we don't want to tell somebody who's major depression to walk it off, right? Treatment's going to be medication and psychotherapy for these individuals. Schizophrenia, that's a brain disorder that affects a person's ability to think clearly. Hallmark symptoms tend to be hallucinations, delusions, disorganized thinking and speech, lack of interest in life and planning, activities, poor hygiene, problems with memory. Just like our bipolar disorder individuals, it's a chemical imbalance in the brain, same with schizophrenia. They're going to need to be on medication for the rest of their life. Okay. It's going to be important if you are caring for individuals with mental health disorders that you observe and report any changes in their behavior immediately. So true or false? Substance abuse is the use of illegal substances in a way that is harmful to oneself or others. All right? It's a little bit of a trick question. It's false because it didn't mention legal substances as well. And like I said, for legal substances, alcohol, tobacco, okay, can be caffeine, glue, paint, permanent markers, even that Robitussin cough syrup can all end up being lead to substance abuse. So factors that can increase your risk of substance abuse, if you have a family history of addiction, it's been known to travel in families, having a mental health disorder or poor coping skills. A lot of times we see in this day and age a huge opioid pandemic. Well, it kind of tends to go hand in hand with mental health problems that haven't been treated. Unstable home environment or taking a highly addictive drug can put you at risk for substance abuse. So taking a highly addictive drug is a risk factor for substance abuse. How do you think this relates to the problem of opioid abuse? Okay, so important to know, opioids are your narcotics. They relieve severe pain. They boost feelings of relaxation, happiness, and pleasure. Their legal and illegal opioids can both cause addiction. Some people may seek illegal drugs to alleviate pain when they're no longer able to obtain the prescribed drugs from physicians. They usually, if you need a narcotic for whatever condition you have, they don't tend to give it to you long term. They give you that short duration. When taking prescribed opioids, a person's tolerance for the medication can actually increase. So they're going to actually start to require higher doses, which can be fatal. Also tends to happen where somebody is suffering from substance abuse and they abstain from taking drugs for a while and they relapse. A lot of the times they pass away from the relapse because they take the same amount or dosage they used to take when they had a higher tolerance. And because of that, it becomes fatal and leads to death. So several times over a few days, nursing assistant Jace thinks he smells alcohol when he is helping Mr. Moss when dressing. Should he tell the nurse that Mr. Moss is an alcoholic? No, right? He should not. We only report our observations. We do not make conclusions. We do not make diagnoses. So all you'd want to report is if you see changes in physical appearance, changes in personality. He'd want to report that smell, the smell of alcohol, cigarettes, or other substances, either in the room or on the clothing. Strong smells of room fresheners can sometimes be seen to cover it up. Increased use of breath fresheners. Constricted or dilated pupils can often mean someone's under the influence of substances. Slurred speech, loss of appetite, forgetfulness, confusion, blackout or memory loss, hiding substances or alcohol, stealing money or valuable, problems with other residents, staff, friends, or family, and thoughts of suicide. All right, everyone. Congratulations. You just made it through chapter 22. Okay, everyone? Good job. So if at any point, if you had trouble understanding that, hopefully with this recording, you can just go right back, revisit it, re-listen to it. Okay, I did skip over the slides that were situational questions because I just wanted you guys to focus on the meat and potatoes. Like I said, these chapters, the systems, very, very much in depth. I'm going over each one in about 20 minutes or so, right? But in reality, when you take anatomy and physiology as prerequisite for nursing school, you go over these systems in months. Okay, so don't feel too overwhelmed. So we're just going to go right into chapter 23, the endocrine system. These are your hormones. So diabetes is a condition in which the pancreas does not produce insulin, okay, type 1 diabetes, or does not produce enough insulin or builds up a resistance. That's diabetes mellitus type 2. Causes problems with circulation and can damage vital organs. As we saw, it can actually affect our eyesight, right? Glands are organs that produce and secrete chemicals called hormones. Hormones are going to be our chemical substances produced by the body that control numerous body functions. Hyperglycemia, hyper, high. Glycemia is our blood sugar. Hyper, high. So this is high thyroid. So hyperthyroidism is a condition in which the thyroid gland, it's a little butterfly gland right here in your throat, okay? So often if the doctor comes in, if you're complaining of fatigue, they'll palpate or feel your throat. They're trying to see if your thyroid is enlarged, okay? But hyperthyroidism is the thyroid is producing too much of that thyroid hormone. And that thyroid hormone is going to cause body processes to speed up and your metabolism to increase. Hypo or low glycemia is going to be low blood glucose or low blood sugar, also known as an insulin reaction or insulin shock. Hypo, low thyroidism, hypothyroidism is a condition in which the body lacks thyroid hormone. Okay, so that's going to cause the body processes to slow down, our metabolism to slow down. Insulin is a hormone specifically produced in the pancreas. So we talked about in diabetes mellitus type 1 or diabetes insipidus, should I say? That's the type 1 diabetes insipidus. Your pancreas isn't making any insulin. Diabetes mellitus, which is usually type 2, is it's built up a resistance to it or it's not making enough. And usually that's a result oftentimes of dietary choices. Okay. Insulin is going to be what moves that glucose from the blood into the cells for energy in the body. A couple different terminologies here. Poly means excessive. Polydipsnia, dyspnea means thirst, so it's excessive thirst. Polyphagia is excessive hunger. Polyuria, excessive urination. And all of these three are signs and symptoms of uncontrolled diabetes. So if we're pre-diabetic, this is a condition in which a person's blood glucose levels are above normal, but they're not going to be high enough for a diagnosis of type 2 diabetes yet. If you are told you are pre-diabetic, you can actually make some lifestyle changes to potentially reverse it. I had a friend, he was young, late 20s, went to his doctor, was told he was pre-diabetic. Well, he loved himself some Mountain Dew. Mountain Dew, very high volume of sugar. And he would drink like at least 12 Mountain Dews a day. All right. And that was his main sugar intake. So he quit. He quit that soda and just started drinking water. When he went back to the doctor, no longer pre-diabetic. Okay. So your thyroid, I said, is that butterfly-shaped gland in your neck. It's responsible for regulating metabolism as well as growth. And this slide here is going to show your endocrine system, okay? So up in your brain, you have your pituitary gland that controls the hormone production of other glands, okay? Glands, once again, secrete hormones, which are chemical substances that control numerous body functions. All right, your thyroid, which is in your throat, regulates metabolism and growth, okay? Also on your thyroid, you have your parathyroids as well. Below your thyroid, you have your thymus, okay? Your pancreas, which is down kind of near your kidneys. Your pancreas produces the hormone insulin. That regulates the amount of glucose available to cells for metabolism, okay? Your adrenal glands are on top of your kidneys. Those are responsible for your fight or flight response. Ovaries in our females, those secrete our estrogen, progesterone, which is responsible for our secondary sex characteristics, as well as having babies, right? And same with men. Men have testes. They are secreting testosterone. They're in charge of helping make the babies by producing sperm. So what are the functions of the endocrine system? It maintains homeostasis, balance within the body through these hormone secretions. It influences growth and development, regulates levels of vitamin D, calcium, and phosphate in the body, maintains blood sugar levels, regulates the body's ability to reproduce, and it determines how quickly cells burn food for energy. Okay, so our metabolism. So the following are going to be normal changes of aging. Your level of estrogen and progesterone decrease in females, particularly the onset of menopause, right? That's why we tend to be at higher risk of osteopenia or osteoporosis, because our estrogen helps with our intake of calcium, so it can affect bone density. Testosterone levels in males usually decrease, but it's not going to stop, right? Not completely, because men are constantly making sperm throughout their lives. Just the quality goes down. Insulin production decreases, and body is less able to handle stress. So we're going to look at some of the words, those descriptive words that we talked about that can be signs and symptoms of uncontrolled diabetes. Polydipsia. If we break down that word, poly, the prefix, means many. Suffix ia is condition, and dips means thirst. So when we can break down these words to their root, the prefix and the suffix, we can understand their meaning better. Okay, so polydipsia is going to be excessive thirst. Polyphagia, excessive hunger. Polyuria, excessive urination. The most common form of diabetes is type 2 diabetes mellitus, okay? It's the most common form. It's caused by the body not producing enough insulin or failing to properly use the insulin. Treatment is going to be monitoring blood glucose levels, diet, weight loss, medications, stopping smoking, and exercise, all right? And once again, those symptoms of diabetes, it's going to be excessive thirst, polydipsia, excessive hunger, polyphagia, excessive urination, polyuria, high blood sugar levels, glucose in the urine, very dry skin, fatigue, blurred vision or vision changes, slow healing, sores, cuts, or bruises. We talked about circulation is very much infected, so they're at high risk of infection and their wounds heal very slowly. Tingling or numbness in the hands and feet, unexplained weight loss, as well as an increased number of infections. Okay, so two situations. Which resident has hypothyroidism? Which one has hyperthyroidism? So the first one, when Mrs. Janik does not take her medication or when the dose is not high enough, she's fatigued and weak. Her blood pressure is low and she feels cold. Okay, so feeling cold, feeling weak, fatigued, that's going to be hypothyroidism, low. Next one, Mrs. Barnes' eyes protrude and she's very thin. Her heart rate and blood pressure are high, okay? Those are signs and symptoms of hyperthyroidism, okay? Hyperthyroidism. So points to review when we're talking about hypo or low thyroidism. It's a condition in which the body lacks the thyroid hormone. It's an autoimmune disorder. Causes can be Hashimoto's thyroiditis, as well as surgical removal of the thyroid gland or radioactive iodine therapy. Symptoms are going to be fatigue, weakness, weight gain, constipation, an intolerance to cold, thinning of our hair or hair loss, brittle hair or fingernails, slow heart rate, low blood pressure, abnormally low temperature. You could get a goiter. So goiter is like a very prominent Adam's apple, almost looks like, right in your throat. Hoarseness, heavier menstrual periods, absence of menses, as well as depression. And treatment's going to be thyroid replacement therapy. Hyper or high thyroidism is a condition in which the thyroid gland produces too much of the thyroid hormone. Primary cause of that is something called Graves' disease. Symptoms include nervousness, restlessness, fatigue, vision problems, or eye irritation. They have this hallmark protruding or bulging eyes called exophthalmos. So I apologize my pronunciation. EXOPHTHALMOS. Exophthalmos. Trembling, intolerance to heat, excessive perspiration, rapid heartbeat, high blood pressure, increase in appetite, weight loss, changes in bowel movements, irregular, even absent menses, and that goiter again they could get. Treatment for these individuals could be anti-thyroid drugs, beta blockers, radioactive iodine, or even surgery to remove part or all of the thyroid. So remember, care of a person with diabetes includes a plan of care, okay, that the nurse, registered nurse, should make, associated with every system of the body. Diabetes must be carefully controlled to prevent complications and serious illness. Nursing assistants must follow the care plan closely, okay? So care guidelines for individuals with diabetes. We want to give frequent skin care. We want to observe the feet carefully for breaks in the skin. We talked about very slow healing wounds, right? It can lead to infection, can lead to gangrene, amputations. We want to encourage residents to follow their exercise plans, report complaints of pain, numbness, or tingling in the arms or legs. Perform foot care very carefully. Make sure you're drying in between those toes, right? Encourage proper footwear. These people have a decreased sensation a lot of times in their feet. They might not notice that their shoes are too tight and creating pressure areas, okay? Carefully follow diet instructions. People with diabetes may work with a registered dietitian or a certified diabetes educator. We want to keep track of residents' tests. We're going to perform blood glucose tests only as directed and if trained. The only person checking the blood sugar is going to be the nurse or a medication-trained CNA, okay? And that's additional training you'd want to do if you wanted to give medications and check blood sugars. We're going to report if a resident does not follow the care plan and report any signs of skin breakdown, vision changes, changes in appetite, increased thirst, that fruity or sweet-smelling breath, weight changes, nausea or vomiting, a change in urine output, any signs of urinary tract infection, fruity or sweet-smelling urine, changes in mobility, numbness or tingling in the arms and legs, nervousness or anxiety, dizziness or loss of coordination, or irritability and confusion. All right, so body systems and where they relate to these symptoms, okay? Vision changes. Vision changes is going to be our nervous system or our sense organs. Somebody has numbness or tingling in the arms and legs. Once again, that's going to be our nervous system. Signs of skin breakdown is our integumentary system or our skin. Change in urine output is going to be our urinary system. And nausea and vomiting are symptoms of our GI or digestive system. So it's important to emphasize that diabetes affects many of our body systems and that signs and symptoms, as well as many changes to a resident's normal, should always be reported. Okay, that's why we want to know somebody's baseline so much, because any deviation from somebody's baseline can indicate something wrong. So why is careful foot care especially important for residents with diabetes? Diabetes have weakened, or people with diabetes have weakened immune systems, so it reduces their resistance to infections. Poor circulation due to the narrowing of blood vessels also increases the risk for infection. So when foot infections are not caught early, they can take months to heal. If the wounds do not heal and lead to gangrene, amputation of a toe or an entire foot or even a leg may be necessary. Like I said, most of my post-status amputations was related to diabetes, unfortunately. So Mina is assigned to provide foot care to Mrs. Frank. What will she do? What must she not do? Is there anything she should observe for and report? Okay. So guidelines for a diabetic foot care, if you want to see in your textbook, is page 446 to 447. So what we want to do, we want to inspect and clean the feet each day. We want to avoid harsh soaps and hot water. We're going to dry the feet carefully. Never going to be cutting toenails, corns, or calluses. Even the nurses do not cut diabetics' feet, okay? It's only podiatrists or foot doctors. We want to use doctor recommended cream or lotion on the feet, but once again, not between the toes, okay? Bacteria loves dark, warm, and moist, so we don't want to leave any moisture in between the toes. We do not use objects to remove dirt from toenails, right? We don't want to use an orange stick. Those are pretty pointy. We don't want any sort of injury to occur. That's why we're not even trimming their toenails unless it's a podiatrist. We want to check their shoes for rocks or other objects. Remind residents, do not go barefoot. And then we're going to report any complaints of pain, tenderness, soft or fragile areas in their feet, burning in their feet, rashes or bruises, changes in color of the skin or nails, especially reddening or blackening, change in the temperature of the skin, excessive dryness of the skin of the feet, breaks or skin tears in the feet, drainage or bleeding of the feet or toes, corns, blisters, calluses, warts, or any ingrown toenails. All right. And we made it. Okay. Good job, everyone. You got one more chapter down, okay? That was chapter 23, our endocrine system. And once again, when you take anatomy and physiology, as you are all very, very intelligent, I'm sure you are going to continue your educations, right? That's going to take months and months to go over. The endocrine system was probably the most challenging for me to learn. So these are just very, very general overviews of them. Okay. Now I'm going to share with you my screen for chapter 24. Okay. Chapter 24 is going to be the immune and lymphatic systems as well as cancer. So we're going to start with some terminology. AIDS. If you break that word down, it's acquired immune deficiency syndrome. This is going to be the final stage of HIV infection, in which infections, tumors, and central nervous system symptoms appear due to a weakened immune system that is unable to fight infection. All right, we've come a long way in the treatment of AIDS. A lot of medications we can use now to help prevent death. As well, we have a lot of medications that can keep somebody just on the HIV status so that it doesn't ever progress into full-blown AIDS. Okay, so an autoimmune disease. This is going to be a disease in which the body is unable to recognize its own tissue and begins attacking these tissues. If we say something's benign, so if I take a tissue sample off your body, okay, and I go to test it. Women, that's, they take a tissue sample of your cervix a lot of time, pap smears. They go to test it. It's to check if it's cancerous or not. If it's non-cancerous, we'll say it's benign. All right, benign. A biopsy. So what's a biopsy? It's a removal of a sample of tissue for examination as well as diagnosis. Breakthrough pain, something we see in individuals with cancer. I also see it end of life a lot. It's a type of severe pain that happens unexpectedly in people who have cancer. I also see it end of life because what ends up happening is if we start giving someone pain medication routinely, we have to keep up with it. But sometimes nurses will come on shift and they'll be like, oh, they look comfortable. I don't want to keep giving them this medication. I'm going to hold off on it. What happens is now that medication slowly leaves their system and they get something called breakthrough pain and they're excruciating pain. Then when I come back on shift, I have to play catch up and I have to give that pain medication more often to try and get through that breakthrough pain to get them back to a stable level. Okay. For cancer patients with breakthrough pain, sometimes they'll have what's called PCA, patient controlled analgesic, where they can control how often through an IV. And then there's usually like a little button. They can control how often they get that pain medication. So what is cancer? Cancer is a general term used to describe a disease in which abnormal cells grow in an uncontrolled way. Homophobia. Homophobia is going to be prejudice, speech, or actions towards the LGBTQ community. Okay, so that's lesbian, gay, bisexual, transgender, and queer. You can sometimes see it with IA plus at the end. I is for intersex, A is for asexual, and plus is for other terms. A lot more terms have come up in the queer community. Okay. Human immunodeficiency virus, HIV. So that's the virus that attacks the body's immune system and it gradually disables it. It can eventually cause AIDS. But like I said, we have a lot of current medications we can use to keep it from developing to HIV or keep HIV, from developing to AIDS. Okay. And as you see in that name, HIV, H stands for human. So can we get HIV from a mosquito, from a tick, from an animal? No. Okay. It only lives in humans, human immunodeficiency virus. There is a feline version of that, feline immunodeficiency virus, FIV. That's once again only in cats. Once again, very, very contagious, unfortunately, through sexual intercourse. And once again, just completely obliterates the animal's immune system. So lymph is going to be a clear yellowish fluid that carries disease-fighting cells called lymphocytes. It's your lymph that is traveling through your lymphatic system, circulating around, bringing the soldiers to the war, so to speak, okay, to battle any pathogens that enter your body. Okay, and think of your lymphocyte as your actual soldiers that are battling those pathogens. If we take a biopsy of a tissue cell and we're like, oh no, it is cancer, we would call it malignant. So benign, non-cancerous, malignant is cancerous. To metastasize is to spread from one part of the body to another. So that's why if somebody is at risk for breast cancer or has it, they have a mastectomy or removal of that breast tissue, we're also removing those lymph nodes in that area. And that's to prevent the cancer cells from metastasizing. Okay. If you have an opportunistic infection, that's an illness caused by microorganisms that don't affect people with healthy immune systems, but they can cause disease in people with weakened immune systems. So you will see when we go to Deauville, there are some people that are on what we call reverse precautions. So they're not actively ill, okay, but they're very susceptible to opportunistic infection. So because of that, they want us to gown up with a bit more PPE than we would standard precautions for these individuals due to their weakened immune systems. And you will see that when we go to Deauville, you'll see the sign on the door. Okay. So remission, if something's in remission, we usually refer to that with cancer. It's the disappearance of signs and symptoms of cancer or other diseases. Can be temporary or can be permanent. Most individuals that are in remission for cancer will still need continuous testing periodically throughout their life to make sure it stays in remission. A tumor is going to be a group of abnormally growing cells. So what are the functions of the immune and lymphatic system? Well, it protects us, protects against the invasion of foreign substances and pathogens, and it also returns extra fluid specifically through the superior vena cava, which is that main vein that kind of dumps into our heart, okay, into the circulatory system. That's why we don't want cancer cells getting into our lymphatic system. If it gets into our lymphatic system, it gets into our circulatory system, those cancer cells can spread anywhere and start to grow. So the lymphatic system, this is a diagram. So as you can see, our lymphatic system goes throughout our body, much like our circulatory system. Lymph nodes are kind of like our houses where most of our soldiers are, okay? And you can see they're in the axillary. You can see them along your throat. So when you go to see the doctor and he's palpating under your jaw and down your throat, he's palpating your lymph nodes, because if your lymph nodes are swollen, that's indicative of a potential infection. Okay. So key points to remember: the lymphatic system removes excessive fluid and waste products from tissues, helps the immune system fight infection. Specifically, the thymus gland makes T cells. T cells attack and destroy specific types of pathogens. Your lymph is that clear yellowish fluid that carries disease-fighting cells called lymphocytes. Okay, and it's important to note about our immune system. Protects the body from harmful substances. Non-specific immunity is present at birth and protects the body from disease in general. Specific immunity is acquired when the body manufactures antibodies as a response to an antigen in the body. Okay. Active immunity is vaccines, causes the body to produce antibodies to protect against that particular disease. And then we have passive immunity. That's a person's given the antibodies needed to defend against the antigen. We see passive immunity very often in newborns that are breastfed by their mothers, right? That passive immunity is going to them. So the following are going to be normal changes of aging. The immune system weakens, causes increased risk of all types of infections. Antibody response is slower. T cells decrease in number, and our responses to vaccines decrease. So I want to remember these points about HIV and AIDS. HIV attacks the body's immune system, and it damages or destroys cells. Cause is going to be the HIV virus acquired through blood or bodily fluids from an infected person. So it doesn't just have to be sexual contact, can be sharing needles, can be any two people with an open cut, right? If you have a cut and your patient who has HIV has a cut and you accidentally touch it, gets into your bloodstream, you can get HIV. Okay. Back in the day, before we were actively testing blood for blood transfusion, people were getting blood transfusions and getting HIV or AIDS, right? And once again, AIDS is going to be the final stage of HIV, okay? HIV stands for human immunodeficiency virus. AIDS stands for acquired immune deficiency virus. So once again, HIV is going to be commonly spread through unprotected or poorly protected anal or vaginal sex with an infected person. They do have medication that can lower your risk of getting HIV called PrEP, P-R-E-P. Okay, it has to be taken on a daily basis to prevent your potential getting HIV. Sharing drug needles or syringes. And in healthcare settings, infections can be spread through accidental contact with contaminated bodily fluids, needle and sharp objects, or other contaminated supplies or equipment. So how is HIV not spread? Can I give it to you in a kiss, in a hug? No, right? No. Okay. It's not spread through the air, water, or food. It's not spread by pets or insects, including mosquitoes. It's not spread in saliva, tears, or sweat. Okay. Hugging, shaking hands, sharing dishes, touching doorknobs or toilet seats, you're going to be fine. Okay. Closed mouth or casual kissing, you're going to be fine. The only time you'd have to worry kissing is if they had any open areas in their mouth sores. So for each of these ways HIV can be transmitted, what's one way we could stop it? Okay. Unprotected or poorly protected anal or vaginal sex with an infected person, right? Wear a condom, right? Wear a condom or take that pre-exposure prophylaxis, that PrEP, okay? If you've had contact already with someone, you didn't take PrEP, there's something called PEP, post-exposure prophylaxis. That medicine has to be taken within 72 hours after possible exposure. Okay. Get tested for HIV and retested if necessary. Okay. Sharing drug needles or syringes, don't share them, right? Reducing the number of sexual partners or even abstaining from intercourse can help. Okay. Accidentally contact with contaminated bodily fluids. You want to make sure you're wearing your PPE, practicing standard precaution, handling and disposing of shops properly. You want to cover cuts, sores, tears, breaks, or rashes before caring for residents. And if you have potentially been exposed, take PEP, post-exposure prophylaxis. So what are the signs and symptoms of HIV and AIDS? So HIV is going to be flu-like symptoms, shaking, chills, skin rashes or sores, night sweats, muscle aches, sore throat, and swollen lymph nodes. When it progresses to AIDS, you have rapid weight loss, diarrhea lasting longer than 1 week, pneumonia, discolored blotches on or under the skin or even inside the mouth, nose, and eyelids, memory loss, and depression. And once again, we've come a long way in treating HIV. HIV does not always progress to AIDS. So remember, people with a weakened immune system due to HIV or AIDS may get opportunistic infections or diseases that a healthy person would be able to fight off. It's important to note that the lack of treatment for HIV/AIDS is going to increase that risk of serious complications and death from the disease. So what type of illness occurs when the body is not able to recognize its own tissue and attack back? Well, when our body's attacking its own tissues, we call that an autoimmune disease. So it's important to note that the body's going to be unable to recognize its own tissue and it attacks it. Examples, lupus, rheumatoid arthritis. All right. The cause is unfortunately unknown, but we are wondering potentially if that there's a genetic link. Microorganisms or medications can act as triggers. Signs and symptoms include fever, fatigue, dizziness. Treatment's going to include hormonal supplements, medications, blood transfusions, and insulin. So how does care for a resident with HIV or AIDS differ from care from any other resident? Should it differ? No, right? Because we should be following standard precautions with every single resident in our care, treating everybody like their bodily fluids or blood could be contagious. So there should be no physical difference in care given, okay? Quality care is person-centered. Each resident has different needs, but residents with HIV and AIDS require no additional PPE or other infectious prevention precautions. So how can we provide a safe environment for residents with HIV or AIDS? Well, we're going to follow standard precautions, right? Cover all broken skin with appropriate bandages before giving care. Wear appropriate PPE. Wash our hands and other areas of the body immediately after contact with blood or bodily fluid. Handle and dispose of sharps carefully in those sharps containers. Remember, they're those kind of big red ones, usually hanging on the walls in bathrooms. Remind residents and visitors to wash their hands often. We never want to share residents' personal items, and we want to properly disinfect surfaces. So we want to remember these facts specifically about cancer. Usually occurs in the form of a tumor that grows on or within the human body. Tumors can be either benign, we said benign's non-cancerous, or it could be malignant. We said malignant is cancerous. Can act in different ways, and it can metastasize. Metastasize is spread to other areas of the body. So that's why a lot of the times if somebody has cancer and they said it's gone to your lymphatic system, they're very, very much worried about metastasizing. So there are different risk factors for cancer. Some can be genetic, cannot be controlled. Others can be controlled, all right? So ones we can't control are going to be those genetic factors, right? But we can control our lifestyle choices. Tobacco use, alcohol use, poor diet, obesity, lack of physical activity, Certain infections, environmental exposure, such as radiation, and sun exposure, wear your sunscreen, SPF 50, can all be risk factors for cancer. So remember, many signs and symptoms of cancer are similar to signs and symptoms of other conditions. So it's important to observe and report any changes in residents. Remember, that's your main job as CNAs, is your observational skills, okay? That's what CNAs are doing. You're observing. It's the nurses who are going to be assessing, and it's going to be the doctors who are prescribing, okay? So signs and symptoms of cancer is identified by the American Cancer Association. It's going to be unexplained weight loss, fever, fatigue, pain, skin changes, changes in bowel or bladder function, sores that do not heal, white patches inside the mouth or on the tongue, unusual bleeding or discharge, any thickening in breast, testicle, or other area, ingestion or indigestion or difficulty swallowing, a new mole or change in appearance of existing mole or wart, or a nagging cough or hoarseness. Kind of the symptoms depend on what part of your system is affected, right? So we're going to use some of our use terms from this learning objective to finish this sentence. A blank is one test often done to diagnose cancer. Tissue is removed and examined for abnormal cells. After a diagnosis is made, a treatment plan is developed by a blank. The goal of treating cancer is to cure the cancer, have it go into blank, or provide blank care if it is incurable. So now we're going to answer those, okay? It's a biopsy. A biopsy is one test often done to diagnose cancer. Tissue is removed and examined for abnormal cells after a diagnosis is made. A treatment plan is developed by an oncologist. Oncologists are cancer doctors. The goal of treating cancer is to cure the cancer and have it go into remission, or provide palliative care if it's incurable. So palliative care, we're not going to try and cure the cancer anymore. We're just going to work on treating the symptoms as the disease progresses and eventually leads to end of life. So there are various treatments for cancer that are often in combination. Doctors or the oncologist, as well as family preferences, are going to decide what type of treatments they have. They could have surgery, radiation therapy, chemotherapy. Chemotherapy is more systemic. Radiation therapy tends to be more specific to that area. Hormone therapy and immunotherapy. So it's important to follow infection prevention guidelines when caring for residents with cancer. We want to follow standard precautions and wear our PPE as required, personal protective equipment. Especially on individuals that are undergoing treatment like chemotherapy, radiation therapy, because it can decrease or affect your immune system. So a lot of times these individuals can get opportunistic infections. So we need to be very careful. Because chemotherapy doesn't just kill the bad cells, it kills the good cells too. All right, that's why people get so sick on it. So why do you think residents with cancer need especially careful skin care? All right, because once again, infections can be especially dangerous. Okay, we want to observe the skin to prevent pressure ulcers, change positions every 2 hours, follow special skincare orders exactly. Use special mattresses or pads and beds and chairs to reduce the risk of pressure ulcers. Keep the skin clean and dry. Apply lotion to dry skin. Do not use lotion on areas receiving radiation therapy. And then if there's markings around the area they're doing radiation therapy, you need to make sure you leave those alone. And then you want to report any signs of infection. So residents undergoing cancer treatment may have bad taste in their mouth. A lot of times they get a metallic taste from medications or from vomiting. So things we can do to help as CNAs. We can give oral care often. Be gentle. Use soft brushes, or even if the soft brush is too much, because sometimes they can have excessive bleeding when you try and brush, just use those swabs that we had in our lab. Use mild mouth rinses to reduce the bad taste from medication and vomiting. So why is good nutrition especially important, right? Because residents with cancer need to eat and drink enough to maintain their energy level. Unintended weight loss can occur with cancer or cancer treatment. Okay, so we want to provide our cancer patients with small, frequent meals to reduce nausea and prevent weight loss. We want to serve their favorite foods. That is best, right? Just get food into them or nutritious snacks. We want to provide food when hunger occurs. We want to try cool or cold foods. Can be easier to eat than warm ones. Cut foods into smaller pieces. Use plastic utensils because metal ones can kind of reinforce that awful taste. Weigh residents as ordered and report weight loss or gain. And then always we want to encourage fluids and monitor I&O, intake and output, and report any changes. So we want to know these guidelines for bladder and bowel changes for residents with cancer. We want to assist residents with toileting often, give catheter care as needed, carefully measure output, and then we might have to test the stool for occult blood, hidden blood as ordered. So remember, cancer can cause severe pain, including that severe unexpected pain called breakthrough pain. It can affect the ability to sleep, eat, move. Medications and other measures are used to treat the pain, and we want to observe and report signs of pain in residents with cancer. Like I said, when I've had an end-of-life patient and people stopped giving them their pain med because they're like, oh, they're comfortable, and then they have this breakthrough pain. Oh, it's horrible to see. Moaning, thrashing. I had a resident once literally throw themselves out of bed with movement from so much breakthrough pain and discomfort. All right. So why do we think it's especially important to report changes in body temperature in a resident with cancer, right? Because what do high temperatures indicate? Fever, and fever can mean infection. So we want to make sure we're monitoring all vital signs, especially temperature. We want to report any changes in vital signs to the nurse. And we do not want to measure blood pressure on the side that has had surgery or is swollen. We worry about lymphedema. So like I said, if I had a mastectomy on my right side, I'm not taking a blood pressure on that right arm. Okay. And that is the end of the meat and potatoes for our lymphatic and cancer chapter. All right, everybody. So now I'm going to go right into chapter 25. Okay, so chapter 25 is rehabilitation and restorative care. So we want to work with our terminology. So abduction, to abduct or move away. We're moving a body part. So if I have my legs like this and they were together and I moved my leg out, that's abduction. Adduction, bringing it back to center line. So moving a body part away from the midline of the body. Active assisted range of motion. Active assistive range of motion are going to be exercises to put a joint through its full arc of motion that are going to be done by a resident with some assistance from staff. Okay, so they can do some themselves, but might need some cueing and a little bit of help. Active range of motion, AROM, are exercises to put a joint through its full arc of motion, and they're going to be done by the resident themselves. They don't need any help from you. Once again, adduction is to move a body part towards the midline of the body. Once again, our total hip replacements are on adduction precautions. We don't want their legs to move together or, heaven forbid, cross, because that could actually dislocate the joint while it's healing and it's fresh and new. Assistive devices are going to be all special equipment that helps a person who is ill or disabled perform their ADLs, their activities of daily living. Dorsiflexion is to bend backwards. Okay, so if this was my foot and I bent my foot up like this is dorsiflexion. Extension is to straighten a body part. So if my arm was bent like this, flexion, extension. Flexion, extension. Okay, flexion, bending a body part. extension, straightening that body part. Foot drop is actually a weakness of muscles in the feet and ankles, and it interferes with the ability to flex the ankles and walk normally. Hyperextension is what we always want to prevent when we're helping somebody with range of motion. We don't want to go past their ability of what their normal range of motion is. So hyperextension is extending a joint beyond its normal range of motion. And once again, you can cause injury or, potentially permanent damage to that joint. Opposition is a type of range of motion you might do with somebody where you actually take the thumb and you touch every single finger with it. Okay. Orthotic devices are devices applied externally to limbs to support, protect, improve function, and prevent complications. Passive range of motion, PROM. This is one you do most often. Once again, any range of motion exercises are ordered by doctors. But in the passive range of motion, these are exercises to put a joint through its full arc of motion that are done by a staff member without the resident's help. So you are fully supporting the joints. So when we practice this in lab, if you're doing the upper arm, right, you want to support the joints, the wrist, the elbow, when you're helping move that arm up, and you're supporting all of its weight. All right. Physiatrists are doctors who specialize in rehabilitation. And that's PHYSIATRISTS, right? Physiatrists. And I apologize if I'm pronouncing that wrong. Okay. Pronunciation's never been my strong suit. But once again, you don't need to know pronunciation for your test. You just need to make sure you can know what that word looks like and know how it's spelled. So pronation. Pronation is turning downward. So pronation with my head. Okay. Pronation, turning downwards. Or with my hand was up. Okay, turning my wrist. This would be pronation. Range of motion is that umbrella term. It's exercises that put a joint through its full arc of motion. Rehabilitation. So that's care that is managed by professionals to restore a person to the highest possible level of functioning after an illness or injury. Restorative care, care given after rehabilitation to maintain a person's function and increase their independence. A lot of people will come to us, long-term care facilities have a rehabilitation unit. So most of the time somebody's in the hospital, they're elderly, they'll come to us for rehabilitation. Restorative care I often see nowadays in home health. So people will get discharged from a rehab unit, and then restorative care can happen at home with the presence of therapists and home health aides. So rotation. Rotation is going to be turning a joint. Okay? Rotation. Supination, turning upward. Supination. Okay? Or if it was my hand, supination, turning upward. Turning upward. Okay? So we're going to use some key terms from this learning objective to finish these sentences. Blank is care used to restore a person to her highest level of functioning possible after an accident, illness, or injury. A team of skilled healthcare workers, including blank, who are doctors specialized in rehabilitation, provide care. After rehabilitation goals are met, blank blank may be ordered to improve quality of life and increase independence. So let's take that first sentence. It's going to be rehabilitation. Rehabilitation is care used to restore a person to her highest level of functioning possible after an accident, illness, or injury. A team of skilled healthcare workers, including physiatrists, doctors that specialize in rehabilitation, provide care. After rehabilitation goals are met, it's going to be restorative care. May be ordered to improve quality of life and increase independence. Okay, so do you think rehabilitation for these two residents will progress at the same speed? Why or why not? We have Mrs. Klima. Mrs. Klima was a college basketball star as a young woman. She went on to coach basketball for many years and stayed very fit. She's in rehabilitation after a stroke left her partially paralyzed. Then we have Mr. Romero. Mr. Romero was a professional pianist. He was in a car accident and his hands were seriously injured. He is not very interested in rehabilitation because he knows he will not be able to play the piano again. So when we're looking at these two situations, we want to see what's going to affect progress in rehab. One, how soon it began, any pre-existing conditions or injuries, overall motivation. I find motivation to be a huge one in rehab. If you don't want to do therapy, you're not going to get better, right? The type of facility where a resident resides, the combined efforts of the staff, attitudes of the rehab team, and consistency in following the care plan. So when I look at both of these, I see more hope for Mrs. Klima, right? Because before all this happened, she knew how to exercise. She stayed fit, okay? She was active. So somebody who's already exercising, right, is going to get back into it. It's going to be easier for her to probably participate in therapy than maybe Mr. Romero. Mr. Romero is feeling maybe a bit depressed, a bit hopeless about his situation, saying he doesn't want to do therapy. So I'm going to be more worried about Mr. Romero's therapy compliance than maybe Mrs. Klima, how she's doing rehabilitation. Because she has a better prospect, a better outlook. So remember, for rehabilitation to succeed, all staff members must work together to return the person to their highest level of functioning. The rehabilitation team is made up of highly skilled and trained professionals, including but not limited to you nursing assistants, right? We also have the physiatrists, the speech therapists, physical and occupational therapists. We have nurses, social workers, discharge planners, residents, and of course, residents' family and friends, which the most important person on a care team is who? Our resident. So goals of rehabilitation are going to include helping residents maintain or regain their abilities. We want to promote independence and help the residents to adapt to maybe what their new norm is and prevent complications of immobility. And once again, those complications of immobility that we look at, why we want to move somebody every 2 hours, right? Atrophy, weakening of the muscles, and contractures, painful shortening, okay, of our joints. So remember, when the goals of rehabilitation have been met, restorative care may be ordered. Restorative care works to maintain a person's functioning and it also to increase their independence. So what we want to do with restorative care, we want to make sure we understand the diagnosis, the disability, and any limitations the resident might have. We want to be patient, often praise frequently, maintain a positive attitude, listen as much as possible, provide plenty of privacy, encourage independence, encourage daily activity, accept setbacks, they do happen, and focus on what the resident can do. We want to report observations to the nurse, specifically any change in their ability. If they're starting to develop a decrease in strength, lack of motivation, very, very huge in rehabilitation. Sign of withdrawals or depression could affect their motivation, so I'm going to want to know. So how could a nursing assistant adapt their motivational style to fit different personalities? Okay, so say you have Mrs. T, she's shy, she's quiet, she's learning how to dress herself. You might use less verbal cueing and more hands-on, gentle approach, right? You might lower your voice, meet her at her level, mirror kind of her personality, if you will, to make her feel more comfortable, right? Say you have Mr. M. Mr. M is very proud, retired, Marine major, and he has to learn to feed himself, okay? You might really want to think about dignity and privacy when he's still learning, if he's still making like a little bit of a mess, so give him that privacy. Maybe he'll want to eat and you can put him with a volunteer, a veteran volunteer that could sit with him. I have very much found my veterans like to be around other veterans. Say you had another woman, Mrs. G. She's a grandmother. She has to learn to use a leg brace to walk. I would use the grandkids as motivation, right? Maybe have the family come in and help her, learn too how to put on the leg brace and help grandma, right? Use those motivational cues. What makes them tick? What makes them happy? What prize or reward is at the end of getting back into therapy, right? So even though it may be faster and easier for you to do a task yourself, it's important for you to encourage independence in your residents and to allow them to do as much for themselves as possible, okay? Regardless of how long it takes or how poorly they're able to perform it, okay? Even if you could do a task better or faster, you got to be patient and encourage each resident to perform as much self-care as possible. Independence helps self-esteem, along with speeding recovery. Self-care also helps the body stay active, and it prevents complications of immobility. So how do you think it would feel to need help lifting a fork to your lips at mealtime? How would it feel to need help getting dressed in the morning? Right? We always have these questions because we want to take it as an opportunity to think about how the residents feel and to create empathy. Empathy is what pulls us through those rough days and helps us with those more challenging behaviors and situations. So remember, activity is an essential part of a person's life. When a person becomes immobile or inactive, the body does not respond well. All right? You use it or you lose it. So staying active is very important. Immobility affects every body system. Okay. Your GI, gastrointestinal, can cause constipation. Urinary, you can get UTIs, urinary tract infections. Integumentary, our skin, we can get pressure ulcers or slow healing wounds. Circulatory, we can get blood clots, especially in our legs, those DVTs, deep vein thrombosis. Respiratory, we're not exercising or being able to fully expand our lungs, can lead to pneumonia. Musculoskeletal can lead to muscle atrophy, that wasting away of the muscle, and contractures, painful shortening of the ligaments, okay, in our joints. Nervous system can lead to depression, insomnia, and endocrine can lead to weight loss. It slows down our metabolism. Okay. So how does exercise benefit these different systems? GI, you eat better, okay? Aids in regular elimination. Urinary, it improves elimination and it helps to decrease the risk of infection. Integumentary improves the quality and health of our skin. Circulatory improves circulation. Respiratory reduces the chance of infection and it improves our oxygen levels. Musculoskeletal increases blood flow to the muscle and improves strength. Nervous system, it improves relaxation and sleep. And then endocrine, it's going to increase metabolism and help to maintain a healthy weight. Okay. So when would our residents use certain assistive devices, such as a cane, a walker, a crutch? All right. Well, a cane, start with the first one, helps with balance. Okay. A walker helps with balance and can bear some weight, and crutches are going to be used when clients can bear no weight or limited weight on one leg. So we talked about in the musculoskeletal system how people can be on orders, non-weight bearing, partial weight bearing. So that can affect what assistive device you use. Okay. So once again, canes are going to help with balance, but they do not completely to support weight. There's different types of canes. C cane, functional grip, and quad cane. The quad canes are the ones that have the 4 prongs at the bottom of it. Walkers help with stability and some weakness. You can even find those rolling walkers that lock and have a seat so people can sit and take frequent breaks if they get tired with ambulation. Crutches are used when a person can bear limited or no weight. Okay. And with all of these, we want to encourage empathy, especially for residents who do not need mobility aids previously. It's going to be a big adjustment, and they could go through the stages of grief when you're losing your independence like that. So safety. Safety is key when assisting with ambulation. So how we want to keep our individuals with assistive devices safe. We want to check canes, walkers, crutches for damage before using. We want to make sure the resident is wearing fastened and non-skid shoes or slipwear. We want to have residents use a cane on their strong side, okay? Their weak side's not going to be able to hold it well. So it's on their strong side. And then they put that cane forward and they move it with their weak leg to kind of offset that balance and to help with that strength. You do not want to hang heavy items on the walker. We always want to encourage proper posture. So when somebody's using a walker, they need to step into it. Sometimes you'll see them start to bend forward and overhang. Nope, I'm right. Step into the walker. Move it out, step in. You want to stay near the person on their weaker side when you're walking with them. Do not rush them. Move the resident from bed or chair if they experience pain. Pardon me. Return the resident to bed or chair when they're finished with their ambulation. So assistive devices can help people who are recovering from an illness or adapting to a physical disability. So examples of that are going to be special combs, plate guards. Okay, so those are those guards that go on the edge of the plate that can help put the food on their silverware. Those grabber extensions, if they can't reach for something because they're inhibited, they can use those grabbers to reach around them. Certain eating utensils have thicker handles and sometimes even straps to secure hands, say if you had a tremor, as well as positioning devices can all be examples of assistive devices. So remember, positioning devices are used to help prevent complications from inactivity and immobility. These devices aid in proper body alignment as well as positioning. So potential positioning devices you could find: backrests, foam wedges. Sometimes they'll have a footboard. The footboard actually helps prevent foot drop. Bed cradles. Bed cradles like a little frame that goes on the base of the bed and you put blankets over it so it doesn't create any pressure points on the toes. Abduction pillows, wedges or hip wedges, trochanter rolls, hand rolls, all different types of equipment you'll see. Finger cushions, elbow protectors, and orthotic devices. Main, honestly, device you're going to use, pillows. Okay, you might not have a lot of these devices, so you use pillows to help positioning and alleviate pressure areas when you're repositioning people in bed. So we're going to use some key terms from this learning objective to finish this sentence. Blank exercises put a joint through its full arc of motion. This is going to be that umbrella term, range of motion. Range of motion exercises put a joint through its full arc of motion. Blank are done by the resident alone without help. That's active range of motion. Blank are done by the resident with some help from staff. That's active assisted range of motion. And then the last one, blank are done by a staff member without any of the resident's help. That's passive range of motion. And passive range of motion is what you work on during Skills Week and is something you could get on the state test. Specifically, they only have you do either one arm or one leg. All right. And this slide is just a body movement. So showing abduction is moving away from the midline of body, adduction, bringing it back, extension, straightening our arm, flexion, bending, dorsiflexion, if this was my foot, moving it backwards. Okay. Rotation. So our shoulder joint rotating. Pronation, moving face down, supination, moving face up. And then opposition, touching our thumb to every single one of those fingers. All right. And that's the end of another chapter, everybody. There we go. Okay. So that was chapter 25. So I'm going to keep going. Okay. These last 3 chapters are pretty small. And I'm just waiting for them to load up in my PowerPoint. I keep looking at my dual screens thinking I'm going to see all your faces and then all I see is mine. So if you see my side profile, it's like when we're doing in-person Zoom meetings, I think I'm going to see you and then I don't. All right. Whoop. Pardon me. My PowerPoint's taking just a little bit to get going. Okay. Okay, so we are going on to chapter 26. Okay, chapter 26 is subacute care. Okay. So central venous line is going to be a type of intravenous line, IV, that is inserted into the large vein in the body. Okay. Chest tubes are going to be hollow drainage tubes that are inserted into the chest to drain either air, blood, pus, or fluid that is collected inside that pleural space or cavity. That's that space around the lungs. Okay. I cannot insert chest tubes. That is something only a doctor can do. Okay. And it has to be sealed. That makes sense. So the tube actually goes directly into a water filtration system because we don't want air escaping back into it. Delirium is a sudden state of severe confusion due to a change in the body. But the thing about delirium, why it's a little different than, say, hallucinating or delusions, it's an acute confusional state. Okay. So delirium is usually a side effect or a symptom of something else going on in the body. Okay. That if we treat the disease or the illness, we can reverse it. Gastrostomy. Gastrostomy is going to be a surgical opening that we actually make in the abdomen and stomach. We often refer to it as a G tube. Okay. So for individuals that are NPO, nothing by mouth, they can't eat anything through their oral cavity, I can give them food or fluids through their G tube. And once again, that's something only the nurse can do. Only the nurse can do tube feedings. Hypoxemia. Hypo means low. Xemia, IA, is a condition. Okay. Oxygen. So this is low levels of oxygen in the blood. Right. Intubation. Intubation is going to be the insertion of a plastic tube through the mouth or nose into the trachea or windpipe in order to place an artificial airway. I know a lot of these terms, once again, we're repeating a lot, but just to make sure you remember from our respiratory system or gastrointestinal system. A mechanical ventilator, you might see those in subacute care. This is a machine used to inflate and deflate the lungs when a person cannot breathe on their own. We talked about DNI. So if somebody's a DNR, they're do not resuscitate. DNI, do not intubate. So those people are saying, I don't want to be intubated. I don't ever want to be put on a mechanical ventilator. If I can't breathe on my own, let me go. Right. Nasogastric tube. I can, as a nurse, actually put in these. Nasogastric tube usually goes up the nose, down through the trachea, into the esophagus, into the stomach. Okay. It's a feeding tube. And what I usually do, I want it to go through the right hole. So I'm going to ask them to tuck their chin. I'm going to use lubrication, feed it up their nose, and ask them to repeatedly swallow, because I want their epiglottis to shut off, okay, the pathway into the lungs, and I want to make sure it goes into the stomach. And that's what it is. It's a feeding tube that is inserted through the nose and into the stomach. Percutaneous endoscopic gastrostomy, otherwise known as a PEG tube. So that's the tube delivered through the abdominal wall into the stomach to deliver liquid nutrients and medications. Like I said, we just call it a PEG tube. Pulse oximeter is a device that measures a person's blood oxygen level and pulse rate. All right. So a lot of times you don't even need to take those radial pulses. It will read right on your pulse oximeter. And like I said, we want those blood oxygen levels to be as close to 100 as possible. But a lot of times in my individuals with COPD, the highest you can get it is 88%, and that's on 4 liters of oxygen. But that's due to their ineffective alveoli, the alveoli that have air trapped in it or have collapsed where they can't take that full breath, so they don't have great oxygen gas exchange in the alveoli. Sedation is going to be a use of medication to calm a person. You can have conscious sedation for certain types of surgery. Okay. Sepsis. Sepsis is a serious illness caused by an infection, usually bacterial, that requires immediate care. When somebody goes septic, usually that infection is now going through their bloodstream and it's systemic. Telemetry. If any of you are interested in advancing in nursing, telemetry is a great career choice if you want something a little bit more calmer and a stable schedule. Most of the time, they're not working weekends or holidays. They're basically going in, and it's the application of cardiac monitoring device. So you go in, you put on those little leads all over their chest, you go back to the nurse's station, and then you're just monitoring it. You're monitoring for heart rhythm and heart rate. Okay. And then it will be a doctor that interprets those results. So I do have a cousin that's a telemetry nurse and she loves it. Okay. Total parenteral nutrition, TPN. So this is when we have to completely bypass the GI system, the digestive system, and we're going to do intravenous infusion of nutrients in its basic form directly through the vein. Okay, and it's going to be absorbed directly by the cells. We're bypassing that digestive system. So we want to remember these facts about subacute settings. It's for people who need more care than most long-term care facilities can provide. Hospitals and long-term care facilities may offer a subacute care. I have had facilities where their rehab and subacute tends to be one and the same. Residents need a higher level of care than other residents, and they'll require more direct care and more close observation by staff. So in what situations do we think residents may need subacute care? All right, so like we said, these are going to be residents who need more care and observation than other residents, especially long-term care. They're going to be residents who've had recent surgery or chronic illnesses such as AIDS or cancer. They could be residents with serious burns who need special administration of nutrients or medication or need dialysis. They're going to be residents who are on a mechanical ventilator. And once again, the mechanical ventilator is a machine that inflates and deflates the lungs when a person cannot breathe on their own. So remember these points about pulse oximeters. Okay, they warn of low blood oxygen level before signs develop. The normal pulse oximeter reading is 95 to 100, but it can differ depending on the person and their conditions. Like I said, my COPD, I'm lucky if I get it to 88, maybe 90. All right, and that's with 4 liters of oxygen on. We want to report any changes of oxygen levels to the nurse. So it's important to note that sometimes pulse oximeters can be inaccurate. Particularly, studies have shown darker skin pigmentation and melanin, so readings in Black, Hispanic, and Asian patients are more likely to be inaccurate. As well, artificial nails, nail polish can interfere with the readings, okay, as well as poor circulation. If their hands are cold, you're going to have a hard time reading. So a lot of the times I'll go and I'll warm up their hands a bit, okay, before I try and take that reading. So once again, guidelines for pulse oximetry: no artificial nails. Be careful when moving and positioning. Usually that hand has to remain still, so you can't put it on and have their hands waving around. You're not going to get a good reading. You want to report to the following if any alarm sounds, or if you start to notice they have difficulty breathing, discolored skin, changes in vital signs. And if you want to see the procedure for applying a pulse oximetry device, it's on page 481 of your textbooks. 481. So true or false? Telemetry is a form of monitoring that checks a resident's breathing patterns and oxygen levels. It's false, right? False. Telemetry is the application of cardiac monitoring device. So it's cardiac, not respiratory. Transmits information about the heart's rhythm and rate to computer screens at the monitoring station. So remember, an artificial airway is needed when the airway is obstructed due to illness, injury, secretions, or aspiration. It is sometimes needed when a person has surgery. Intubation is going to be the procedure of inserting that artificial airway. So is a trach tube the only form of intubation? It is not. It is not. Intubation is the insertion of a plastic tube through the mouth, nose, or opening in the throat, tracheostomy, that goes straight into the trachea, or windpipe in order to place an artificial airway. A trach tube is placed through a tracheostomy, opening through the neck. Okay. So imagine what it would feel like to have an artificial airway. What can we do to provide empathetic care, right? Important things to note: anybody that has an artificial airway, we want to tell the nurse if that tubing comes out. Follow orders for positioning. Check vital signs as ordered. Perform oral care often, at least every 2 hours. Report biting or tugging on the tube. Write notes or draw pictures or communication boards, and high signals can all work for communication if the resident can't speak. Do not Move or remove any spare artificial airway tubes or other equipment by the bedside. Okay, we need that handy if anything comes out. You want to report signs of respiratory distress. That's going to include wheezing, unusual breathing sounds, difficulty breathing, cyanosis, pale, gray, or darkening skin on the mucous membranes, changes in vital signs, drainage, secretions in tubing, or nervousness or anxiety. So in what situations do we think a tracheostomy would be used? Okay. Obstruction. Okay, so if anything's obstructing their airway, we might need a tracheostomy. Cancer, infection, severe injury, severe allergic reaction, coma, facial burns, gunshot wounds, and then we might also need it to prevent aspiration in an unconscious person. So remember, nursing assistants must use alternative methods of communication if a resident cannot speak. It's important to answer their call lights promptly. Okay, and this includes taking care of residents that are a different language. Sometimes I have to play the mind game. Okay, you know, would you like something to drink? Are you hungry? Would you like to go to bed? Okay, these are all things that sometimes you can learn to kind of overcome that inability to speak. So even though nursing assistants do not perform tracheostomy care or suctioning, you still have an important role in careful observation and reporting. So guidelines that you're gonna have to follow for tracheostomies. We want to answer those call lights promptly. Use alternative methods of communication. Follow orders for positioning. Don't tire out the resident. So if you're doing the procedure, they're getting a little short of breath, you stop, just like with our COPD patients. We want to check vital signs as ordered. Inspect ties or tape often. Okay, they kind of keep the tubes together. We want to make sure they're securely on. Keep the dressing dry. Do not cover the tracheostomy opening. Report any kinks or disconnected tubing. Perform oral care often, at least every 2 hours. Right? Observe for mouth sores, cracks, breaks, or sores on the skin. Provide careful skin care. Observe for pale, bluish, or darkening skin or mucous membranes. Do not move spare tracheostomy tubes or bag valve mask. And then you want to report any disconnected tubing, signs of respiratory distress, including wheezing or other unusual breathing sounds or difficulty breathing, cyanosis, pale, gray, or darkening skin or mucous membranes, change in vital signs, especially respiratory rate, mouth sores or discomfort, cracks, breaks, or sores on the skin, or loose or wet tape or dressings. So true or false? Sepsis is a life-threatening illness caused by an infection, usually bacterial. Did you say true? You were right. It is true. It is true. So remember, nursing assistants should be familiar with the resident's normal vital signs, their baseline, so important to know, in order to better recognize changes. This will help them notice the early symptoms of sepsis. Sepsis can advance quick. It's life-threatening, so we need to catch it early. Okay, so we're going to use some key terms from the learning objective to finish these sentences. Blank, blank are hollow drainage tubes that are inserted into the chest using a sterile procedure. Did you say chest tubes? You were correct. Chest tubes are those hollow drainage tubes that are inserted into the chest during a sterile procedure. They are usually inserted by a doctor. You're right, because I'm not doing it. You're not doing it. This is going to be for a doctor. They drain air, blood, pus, or fluid that is collected inside the blank cavity. Yep, it's called the pleural cavity. So which one? Chest tubes are placed in an opening in the trachea or between the ribs and into the pleural cavity. You're right, between the ribs and into that pleural cavity. How about the second one? Nursing assistant's duties may include positioning, observing, and measuring I&O or setting up drainage. Yep. It's going to be I&O, intake and output. You're not setting up the drainage, okay? So important points to remember about chest tubes: they can be inserted at bedside or during surgery only by a physician. They draw air, blood, pus, or fluid out of the pleural cavity, and they allow a full expansion of the lungs. Conditions requiring test tubes can include pneumothorax, that's when it's air, hemothorax, that's when it's blood, empyema, surgery, and injuries. Chest tube is connected, like I said, to a bottle of sterile water, and the system has to be airtight when attached to suctioning. So guidelines, we want to report any signs of these people in respiratory distress or pain. We're going to check their vital signs as directed, report any changes. We want to be aware of where chest tubes are located. Keep the drainage system below the level of the chest, right? We always want to work with gravity. Keep the draining containers upright and level. Keep tubing coiled neatly. Report any clots in the tubing. Observe chest drainage for amount, color, and consistency. Observe dresses for draining, saturation, or bleeding. You never want to remove that equipment in the area. We might need it. Follow orders for positioning. Encourage deep breathing exercises. Provide rest periods. Follow fluid orders and measure intake and output carefully. Report disconnected tubing and signs of respiratory distress and cyanosis. So changes in vital signs, change in oxygen level, or if the pulse oximetry alarm sounds. Complains of pain, coughing up blood, hemoptysis, warmth, redness, swelling, sores, pus. If you notice an increase or a decrease in the bubbling in the drainage system, kinks or clots in the tubing, any change in the amount, color, or consistency or odor of the chest drainage, wet or loose dressings. Nurses want to know so we can replace them. Signs of subcutaneous emphysema, crepitus, such as bulging of the skin or skin that produces a crackling sound. So remember, when a person is unable to consume food normally due to disease or injury, other methods are used. When a person has difficulty swallowing or is unable to swallow, they could be fed through a tube, okay? Nasogastric tube, that's the feeding tube that's inserted through the nose and into the stomach. Percutaneous endoscopic gastrostomy, PEG tube, that's a tube placed through the abdominal wall into the stomach to deliver liquid nutrients and medicines. And then gastrostomy, often called G-tube, a surgically created opening in the abdomen and the stomach. So guidelines for tube feedings. Once again, you're not going to be giving any of those tube feedings, right? It's out of your scope of practice. But what you can do, wash hands thoroughly. Observe carefully for signs of aspiration. Notify the nurse if the alarm is sounding. Follow orders for positioning. Follow fluid and weight orders. Be aware of MPO. MPO means nothing by mouth, right? Give frequent mouth and nose care, and do not pull, tug on the tubing ever. Keep tubing free of kinks. We want to observe for clip falling off. Make feeding time a social time. Report disconnected tubing, tube coming out of the abdomen, any signs of respiratory distress, feeding pump alarm sounding, signs of aspiration, tube feeding liquid gathering in the mouth, cyanosis, pale, gray, or darkening skin or mucous membranes, kinked, plugged, cracked, or broken tubing, leaking or empty bag or container, resident pulling on the tube, or signs of infection at the tube site, such as warm skin, reddened skin, sores, swelling, or pus. So we're going to use some key terms from the learning objective to finish these sentences. If a person's digestive system does not function properly and they're unable to eat, or their nutritional needs cannot be met by tube feedings, blank, blank, blank may be ordered. Did you say total parenteral nutrition, TPN? You got it right, TPN. All right. This is often provided through a blank, 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 which is a type of IV that is inserted into a large vein. Did you say central venous line? You got it right. All right. So remember, central venous lines increase the risk of bloodstream infections. Nursing assistants must observe and report carefully when a resident is receiving TPN. So signs and symptoms we want to report if they have any fever, headache, swelling, redness, bleeding, leaking at the insertion site, signs of fluctuation in blood sugar, or making sure that there is no interruption to the total parenteral delivery. All right, and that is the end of subacute care chapter. All right, you all hanging in there? Like I said, I did skip over a couple slides, but the slides I did skip over were just situational questions, which is definitely more nursing focused than CNA focused. Okay, so I've been skipping over those and just giving you, like I said, those meat and potatoes. All right, so our second to last chapter. This is chapter 27, End of Life Care. So anticipatory grief. This is a period of mourning when the dying person or their family is expecting the death. So when somebody gets a terminal diagnosis, they can actually start going through the grieving process prior to the person passing. We call that anticipatory grief. An autopsy is an examination of a body by a pathologist to try and determine the cause of death. I have not in long-term care had to really do any autopsies. If I did, I wouldn't be calling the funeral home. I would be calling hospital representatives to bring the body there for the autopsy. But like I said, if you go into long-term care, if you go into geriatrics, old age, you're not seeing a lot of those, okay? Because autopsies, we want to figure out the cause of death. Bereavement, that's going to be a period following a loss in which mourning occurs, okay? Most jobs, if you suffer a loss in your family, you get 3 days of bereavement, right? Not a lot of time to mourn. Cremation is the process of burning a dead body until it turns to ash. Some people believe in burial. Some people believe in cremation. Sometimes there's religious reasons. Sometimes it's just personal preferences. There's also many things you can do with someone's ash now. Back in the day, it was just putting it in an urn and on a display. Now you can take your loved one's ashes and actually put it in soil in a tree and have it become part of that tree. You can put it in a pencil and write with them. I've seen people use ash in tattoo ink, and you can actually have that person tattooed on you. So a lot of things they're doing with that. Your death is end of life. It's a cessation of all bodily functions. So when I call a death, I go in with my stethoscope, I place it on their chest, I listen for respiratory, I listen for the heart. If there is a sensation of vital signs, I'm calling the death. Right? Once again, the only person that can pronounce death, LPNs cannot, it's only RNs. Grief is a deeply emotional process that is the response to loss. Different stages of grief, like I said, we'll go over them, and people tend to hop in between the levels. You can kind of keep going through the cycle sometimes. Grief counseling, we definitely want to encourage those individuals that have been grieving for an extended period of time where it's interfering with their activities of daily life. And grief counseling is going to be therapy to try and help a person cope after someone has died. Grief process is the varying emotional responses to grief, which we'll get into. Denial, anger, refusal. Hospice care. So we know hospice care is going to be holistic, a type of compassionate palliative care given to people who have approximately 6 months or less to live. And that's what defines hospice, 6 months or less. And it's available until the person dies. So if they live past 6 months, can they stay on hospice? Oh yeah. Like I said, I've taken care of people on hospice 8 years, all right, that have been on that long. Okay. And they can graduate from hospice if they're not showing a continuous decline as well, and then get back on hospice once they show that decline again. Mourning is going to be the period in which people work to adapt to a loss. It's going to be influenced by culture, tradition, and society. Different people have different periods of mourning. So palliative care, similar to hospice, but we don't need that diagnosis of 6 months or less to live. But it's similar to hospice where we're going to focus on controlling the symptoms. We're no longer trying to cure. So palliative care is care that focuses on pain relief, controlling symptoms, preventing side effects and complications, and maintaining quality of life for a person who is very ill and or is dying. Right? Pathologist is going to be the doctor with advanced training in the examination of organs and tissues. It's the pathologist that does the autopsy to figure out the cause of death. Postmortem care. As CNAs, you will be providing postmortem care, okay? And that's cleansing and cleaning up of the body. When the body dies, the last thing it usually does is it releases all secretions. So any urine, feces still in the body are let go. So you need to do perineal care, cleanse the skin, okay, and make them presentable. All right, you might have to help the family pick out their clothes that they might last wear that they want send along, take off any jewelry the family wants to get, and then the nurse would be the one to call up the funeral home to come pick up the body after the family has sat with the resident and we've provided postmortem care. If this part of the job makes you nervous, it's okay for your first time doing it to ask another CNA to come with you, help you turn the body. All right. And it can be a little scary at first, but it is something you get used to. Okay. Exposure therapy, right? So prolonged grief disorder, PGD. So this is going to be a type of disorder of grief that's characterized by intense emotional pain, and it lasts over 12 months after the person dies, and it severely impacts their daily functioning. So prolonged grief disorder, they're the people that really need to get some grief counseling to help them function. Rigor mortis, that's the Latin term for the condition after death. It happens hours later, where the muscles in the body become rigid and stiff. So if you're worried, oh, Carrie-Ann, how am I going to do postmortem care when they're in rigor mortis? It's going to be a while before they get into rigor mortis, so you're okay. All right. Terminal illness is a disease or condition that will eventually cause death. If it's terminal, it means it's going to cause death. Okay. So we want to understand our goals of palliative care. We want to control symptoms, reduce suffering, prevent side effects, maintain quality of life, and we want to emphasize holistic approach. So remember, when a serious illness is classified as a terminal illness or a disease or condition that will eventually cause death, hospice care is often the next step. Some people are very put off by hospice. They wait till the last second to put somebody on it. And it's sad because it really gives people a lot of extra TLC. You get your own volunteers to read to you, to talk with you, to play music to you. You get your own personal aid. Okay. So I've seen people literally want their loved one on hospice and within hours they pass away. So it's really underutilized, but it's really just about giving that extra TLC, that extra tender loving care. All right. And we're going to really address the social and emotional needs anymore because we can't always address that physical decline. We're just going to treat those symptoms. So remember, a nursing assistant should report complaints of pain or signs of pain immediately. All right, pain control is of the utmost importance end of life. On my fourth, nursing 4 that I took when I was in nursing school, I had to do a research paper, and I actually did it on euthanasia, okay, and why people want assistance to help them die. And the one thing I found is that people are afraid of death because they're afraid of uncontrollable pain, and that when nurses do not hesitate to medicate and keep that pain at bay, they can let nature take its course. All right. I already told my husband, I'm like, babe, when my time comes, you give me all of it. All the morphine, all the Ativan, Haldol, whatever you need, you snow me. You don't worry if I'm sitting there unconscious, okay? Keep me comfortable. Give it all to me, okay? Because you shouldn't have to be in pain when you pass. And I get a lot of resistance sometimes from family being like, I want to talk to my dad. He snowed. Stop giving him all that pain medication. Okay, well, it's a balance. Do you want him to be awake and miserable and thrashing in bed in pain? Or do you want us to medicate him? And yes, he's more of an unconscious state, but he's comfortable. Okay. Morphine, the morphine I give, it's not going to kill them. Slows down respirations, but it's not going to kill them. It's just going to help treat the pain and keep them comfortable until whenever the nature decides it takes them. So, why is it important that residents who are dying have control over their lives for as long as possible, right? Because the resident's life is not in their control at the end, right? We all have a set amount of time. I always tell people money is not the most valuable thing you have in this world. The most valuable thing you have is your time, because there's a limited amount and you don't know how much you have and you don't know when it's over. And it's your trading of time for work, for careers, for your family that you invest in that is your most valuable possession you own, right? So that's why we want to give people at least this level of control as much as we can. Especially important to encourage independence and give the resident control over everything that they can, how they die, right? Who they see, their spiritual leaders. They can't get to decide when they go, but they can decide how they go and in what state of mind they go in. So remember, grief is a deeply emotional response to loss. People who are dying experience grief. So do the people around them. And every person experiences grief differently. Okay. So, and I went into a hospital. My grandma was dying. My uncle, came in and he was all over the place. He's crawling. He's throwing himself on the bed over my grandmother, crying, freaking out. Okay. Now, was he grieving more than my mother, who just kind of sat quietly next to my grandmother with silent tears streaming down her face? No. Or I can give my husband. My husband just this year lost his nana. Not one single tear does he shed. Is he grieving less than my uncle or my mother did? No. He just expresses it differently. My husband's one that holds on to things internally. My mother's one to hold it internally. My uncle, a lot more extroverted, but it doesn't mean any person is grieving less than the other. We all just express it differently, just the same as we do pain. Right? So remember, when a person is dying, there are legal rights that must be respected. Remembering these rights will help you to provide proper care as well as to promote the dying person's dignity. Okay, so what are the rights to caring for the terminally ill? They have the right to visitors, the right to privacy, the right to be free from pain, the right to honest and accurate information, and as always, the right to refuse treatment. Okay, so it may be inconvenient for us to have visitors coming and going at all hours, but if death is close, it's emotional time for all involved. Saying goodbye could be a very important part of dealing with the loved one's death. So we let them come in whenever we want. We try and move the dying person to their own room if we can, to give that resident and their family as much privacy. And then we will put out a refreshment cart because people stay for long times. Give them coffee, tea, some little danishes they can eat. Okay. Might also be very reassuring to the dying person to have someone in the room. We talked about that. Last sense to go is hearing. So I always encourage families, sit around your loved one, talk about all those stories, the happy times, the crazy times, the embarrassing times, okay? Because even if they're not conscious, I fully believe they can hear you, okay? Privacy is always going to be a basic right, okay? Being free from pain, it's very important to monitor our dying residents for signs that they're in pain, especially when they can no longer speak, all right? So knowing the factors that influence feelings and attitudes about death. So what can affect your take on death, your experience with death, your personality type, religious beliefs, as well as cultural background can all affect how you view death. So remember, it is important to honor individual practices and traditions without judging them. So for instance, I had a gentleman, he was dying. Okay, he passed away. He had 3 daughters. After he passed, the 3 daughters wanted us, after we provided postmortem care, to sit up his body. He'd already passed, to sit up the deceased body, put his trophies and awards around him, and they wanted to take selfies and pictures with him. Okay. This is not something I would want for myself. And I've told my husband, I'm like, you are not taking a picture after me after I pass away. Okay. You put all the pictures where I'm alive and smiling and engaging. All right. But leave my deceased body to go. Okay. Get me cremated, let it go. But I didn't want to judge this family. This is what they wanted to do. This is how they were grieving. So I said, okay. We set up the body and we left the room and we let them take their pictures. Okay. I didn't pass my judgment, even though I definitely had thoughts in my head. I didn't pass judgment. Okay. I supported them in their traditions. Okay. So signs and symptoms that we see with approaching death. They're going to have cyanotic, pale, or darkening skin and mucous membranes. Once again, this usually starts at fingertips or feet and works its way up. The body's going to shut down. If it's a machine, what's it going to save last? Our vital organs. So it's kind of going to shut down circulation to the limbs before it shuts down circulation with the vital organs. Skin is going to be cold. Skin can look bruised. We call that mottling. So it's this purple bluish discoloration that starts at the fingertips and feet and works its way up. Heavy perspiration, fever, low blood pressure, increased pulse, chain stroke respiration. So those chain strokes respirations are the okay, you go through a period of fast, shallow, slow, deep, and periods of apnea or no breathing. Gurgling or rattling sound, we often call that the death rattle. We can give this person atropine drops. It helps slightly to dry up those secretions. Difficulty swallowing, decreased appetite and sense of thirst, dry mouth, nausea, vomiting, and diarrhea, and a decreased sense of touch. And I'll be honest, all these signs and symptoms can say death is approaching, but nothing is infinitive. People can go hours, people could go weeks. We don't know. The only one I know definitively are those chain stroke breathing, those chain stroke respirations. When I see those, 48 to 72 hours, and then they're passing. Other ones we can see for end of life: loss of feeling beginning in the legs and feet, extreme weakness and exhaustion, loss of muscle tone, fallen jaw causing the mouth to stay open, inability to speak, loss of vision, dilated pupils or staring eyes, urinary and fecal incontinence, decreased urinary output, hallucinations, extreme drowsiness, disorientation or confusion, loss of hearing. All right. So Latin terms describe changes in the body after death. Rigor mortis, we said, is the stiffness that occurs after death. Livor mortis is skin discoloration after death. And algor mortis is the cooling of the body after death and the decrease in the elasticity of the skin. If you've ever been to a funeral, it was open casket, and you were like, they don't really look like themselves, something with the skin. It's because they've lost elasticity in it. So family and friends may experience different feelings after a loved one dies. You may feel numb or in shock, disbelief or denial, intense sadness, crying, anxiety, fear, anger, or even physical reactions and symptoms such as pain, especially in the chest, nausea, or difficulty breathing, right? These are all the processes of grief. You can go from disbelieving to fear, please don't let this happen, to anger, to crying, all right? And usually the final one, acceptance. So some family and friends may have feelings of guilt, right? Or feelings of relief. Why would we have this? Maybe guilt if we had unresolved problems, if we didn't go visit them as much as we wish we did, right? Or maybe feelings of relief that their pain is finally over. Or maybe if you were their caregiver, relief that you finally have a break, right? Could be all different reasons. So remember, families may direct anger at the staff members. They may just be reacting to the loss of a loved one, but they still might blame staff for a problem that they feel was not addressed. I have had family members blame me before, being like, you gave them too much morphine, or you didn't give them enough. There was nothing I did. This was the progression of their terminal illness, right? But sometimes people need somebody to blame, to be angry at. So whatever the reason, refer any family complaints if they come to you to the nurse. Do not try to calm a family member or friend who is upset with staff. All right, let us handle it. So why is it important to allow family and friends of someone who has died to express their feelings? I'm a firm believer feelings go out or they go in. Okay, if you don't let out your sadness and your anger, it can turn inwards and cause depression and anger at yourself. All right, or a wound that just doesn't heal. Right, if we slap a band-aid over that wound but we never heal it, it continues to fester. So remember these guidelines for helping family and friends. We want to allow the families to show their feelings. Be available. Listen when they want to talk. Don't be afraid to show your feelings. Do not make inappropriate comments or use cliches. We want to report any requests for spiritual leaders to the nurse. So remember, you have the right to experience strong feelings when a resident dies. This is your job. 40 hours a week, you might see these residents more than you do your own family, and they become family. You see them almost every day. It's going to hurt. It's going to hurt when they pass away. And it's okay to say, hey, Carrie Ann, I need a second to cry. That's okay. Leave the floor. I've cried. I have pictures I could show you right now underneath my desk of people whose hands I held and songs I say to them. And I still keep their picture and can look at that picture. And even now I'm thinking about them and I can feel the tears welling up in my eyes because I developed that relationship with them, right? Grief is important. Don't underestimate your own feelings. And if it gets bad and you're still feeling it, don't hesitate to seek out counseling and bereavement, okay? I fully believe it takes a strong person to be able to cry and let out their emotions, right? So remember, before performing postmortem care, we want to be sensitive to the needs of the family and friends after death occurs. So they may wish to stay with the body for a while to say their goodbyes. We want to allow time to do that. We'll ask the family, as the nurse, I'll ask if they want an autopsy. If one's going to be performed by a pathologist to determine the cause of death, they might have to be transferred for another facility. Otherwise, I would ask the family, if I don't have it in the living will, what funeral home they would want the body to go to, and then I would call them to come retrieve the body. So always remember, you want to be aware of religious or cultural practices that the family wants to observe. Everybody faces end of life a little different, especially different religions. So we want to be wary and respectful of that. So things to think about. If you work in long-term care, you might have to do postmortem care. How do you feel about it? Do you think it will be difficult touching a dead body? All right. And if you want to watch the procedure for postmortem care, read about it. That's going to be on page 503 of your textbook. 503. And boom, second to last chapter done. You all are doing so great. Okay. Now we got one more. Okay. And then we shall be all done. Okay, everybody? So the final chapter is going to be chapter 28, your new position. So first and foremost, we go through vocabulary. So conflict resolution, that's the process of resolving conflicts in a positive way so that everybody is satisfied. Do you always get everybody satisfied, conflict resolution? No, right? More, you got to get everybody to agree. All right. Most of the time I have found miscommunications in my staff, particularly my CNAs, are miscommunications. They just don't see the point of view through the other person's eyes. If I can get people to sit down, look at it through the other eyes and make compromises on both sides, then I can find a resolution. Okay. Constructive feedback. This is feedback that involves giving opinions about the work of others in a non-aggressive way. So you don't want to just go to someone and be like, hey, do you want to work on cleaning that up a little better because you made a mess, right? Constructive feedback should have some positive. It's not just negative, okay? And shouldn't be aggressive. It's a way you want to be responsive to constructive feedback because it's going to make you a better CNA. So when you go to apply for your first job, you're going to read a job description. That's going to be an outline of what will be expected in the job. Make sure you read that thoroughly because you want to make sure that they're not going to be telling you to do something that's out of your scope of practice. All right. If you apply for a job, you're going to need to work on a resume. If you haven't done a resume before, Siri in our Salem office, give him a call. He's great. He can help you get your resume and job applications together. But a resume is just going to basically be a summary of your education and experience. Now, as new CNAs, you don't have a ton of experience yet, right? So use your education. You still want to put your work history to show you have a solid work history. Okay. And then any volunteering you've done, anything like that will help. Stress is a mentally or emotionally disruptive or upsetting condition that occurs due to a change in the environment, right? Even positive things can cause us stress. Doesn't have to be negative, right? New house, new baby can be wonderful, but still stressful. So a stressor is going to be any internal or external factor or stimuli that causes stress. So remember, when you begin a new position as a nursing assistant, you got to look for a job. First step in any job search is preparing a well-written resume. Majority of my jobs, I'd say like 75%, I've gotten off Indeed. All right. Indeed has their own format to putting on a resume, but you can also upload your own. And I just love that site because as soon as you upload your resume, have your own on Indeed, as soon as you find a job, unless it's one that says go and apply to our company website, click apply, click apply, click apply. And then there's even a messaging site right on there where you can reach out to job applicants, say, hi, just wanted to check on my job application when they've reached out to you. So it's just a very easy site. It's an easy way to keep applying for jobs. So I always encourage the use of that one. And once again, too, you're going to need references for your new job. If you need a reference, I'm always more than willing to help out my students. Just reach out in an email to me. And if you don't hear back in a few days, just send me a text, okay? So a complete resume is going to have a couple things to it. It's an objective, okay? So you'd put newly graduated CNA looking for a first position in a long-term care facility, right? That's an objective. Mine's a little different. I put, what do I put? Skilled and experienced geriatric nurse, okay? Looking for blah, blah, blah. That would be your objective, okay? You can look up different ones. Your education, of course, will be Royal Healthcare Institute. Experience, you still want to put if you've had any work experience, any volunteer work, skills that might add to it. And of course, you always want 3 professional references. Supervisors are the best, or always someone you work with. You don't want it to be personal references. They do check it. Always make sure you have this information with you too when you go to job interviews. So have your references, email specifically, and cell phone numbers. So imagine if you were hiring for a job and you receive 50 resumes. Okay, which ones are you going to look at first? So I will say it's the ones that are too long, they just don't want to deal with. All right. So you really don't want your resume to be over 1 page long. Should be brief, clear, well written. Make sure there's no typos. If grammar's not your thing, it's not my thing. Have somebody else proofread it for you. Okay. There should be no borders or colors, though I fully admit I have added colors with mine before. 12-point font. Don't staple anything. Okay. Now, cover letters. I'll be honest with you. I haven't done a lot of cover letters in my day. The times I have done cover letters for a job is if 1, it was absolutely required, or 2, do it if you really want the job. Okay. If this is your dream job, do the cover letter. It looks more appealing. It shows your enthusiasm and desire for this position. Okay. So when we begin a cover letter, this is going to be the example of a good one because it gives the most influence. I see that you are hiring certified nursing assistant for your memory care unit at Deauville in Lowell. I recently completed a CNA course with Royal Healthcare Institute, and even put in there like accelerated 4-week course because it's difficult. This is a difficult class. Give yourself bonus points for that. I look forward to working in a setting where my work ethic, attention to detail, and genuine care for others can make a difference. All right, that's going to be the best cover letter to use. Sell yourself. What are you going to do for the facility? Don't state what they're going to do for you. It's what you're going to do for them. So you usually keep it brief. It's usually only 2-3 paragraphs max. It should serve as an introduction to the interviewer, Also say how you're going to advance, okay? A lot of places want to invest in people that are going to stay. So if your plan after being a CNA is to become an LPN RN, say that, okay? Include information about why you're seeking that job, all right? But we're still, once again, going to keep it brief. 2-3 paragraphs max, never bigger than 1 page. So remember, completing a job application can be stressful. Certain places have very extensive job application packets, okay? So being prepared will help you present yourself well. To save time and avoid mistakes, take a piece of paper and write down information that you may need to the application. I save it in my phone. I put my references, my addresses, my times for work history all in there so I have it. Okay, then you can quickly complete that application when you're in. Even if you submitted a resume, they'll still ask you to bring in another copy of it, a paper copy, and fill out their application. So think, what other kinds of jobs have you applied to in the past? What information did you need? Okay, so general information you need on applications, address, phone number, email. They don't usually ask for your social security number anymore. Usually if it's just going to be last 4, or if you're filling out those I-9 forms, okay? But otherwise you shouldn't have that. And I do, by the way, I bring 2 forms of ID in my interview. So if they're like, we want to hire you, I'm like, here's my 2 forms of ID. Okay. Names, addresses, telephone numbers of school or programs you trained, salary information from past jobs, the salary you want. When I was a brand new nurse, I put negotiable. Now I've been a nurse for 14 years. If you don't pay me at least this amount, I'm not going to work for you. Okay. Previous employees and supervisors, name, address, and emails you're going to want on there. Certification numbers and expiration dates from your nursing assistant, your CPR card, your first aid cards, okay? Complete name, addresses, emails, and phone numbers of your personal references. And you're going to want to put down your availability. The greater your availability, the more likely you are to get a job. All right. So remember these guidelines for completing job applications. You want to fill it out carefully and neatly. Never lie on the application, and you do not leave anything blank. So why would a facility or company require a criminal background check to be done when hiring someone to be a nursing assistant, right? It's to protect the safety of the residents. Yeah. I even had to do a credit check and a criminal background check on one. It was an assisted living, private pay. These people had lots and lots of money, right? And a lot of expensive things in their room. So they were very careful about screening. So remember, neatness and appearance, as well as paperwork, can be a factor in getting a job. So take your time writing. Make sure it's nice and clear and concise. And positive. So if it's, why did you leave this job? You know, you don't want to put management stunk, okay? That looks bad, because if you talk about them that way, you could talk about this job that way. All right, so always keep it more positive. Looking for different hour changes or looking not enough hours available. So you don't want to bash your previous place of work. So think, how do you dress for family holiday gatherings? Going out with friends, are they different, right? How are you going to groom yourself for a job interview? So proper grooming guidelines. We always want to bathe, use deodorant. Once again, perfumes, deodorant, we've talked about in the past, can trigger asthma and can be off-putting for some people, so you don't want to use those. Use simple makeup and jewelry, or even none at all. Wash your hands, clean your nails. Basically look like that all you have to do is throw on scrubs and non-skid footwear and you're ready to go work out on the floor, okay? Shave or trim facial hair, wear hair in a simple style, brush your teeth, okay? Check your teeth right before the interview. You don't want a little piece of spinach right there, right? Don't smoke. Smoking smell lingers. Even if you wash your hands 5 times, you can still tell when a smoker has smoked. Wear clean, nice clothes. Dresses and skirts should be not shorter than knee length. Don't wear jeans or shorts. Don't wear t-shirts or anything with a logo or anything written on it. No low-cut tops that show cleavage. Okay, casual professional is what I usually go with. Make sure shoes are polished and don't wear sneakers or open-toed sandals. I usually use like a flat, practical footwear. So think, Formal job interview, if you had one before, how did it go? Was it harder than you expected? Easier? So things you want to do before a job interview, practice beforehand. Find out beforehand if there's going to be a test, particularly nurses. We often have to take a test beforehand. Get directions to the interview site. Do not bring children or friends with you and arrive early. Turn off your cell phone. Be courteous to staff members. Introduce yourself. Smile. Shake hands. Be positive. Look happy, right? Nobody wants a grumpy caregiver. Don't eat or chew gum. Oh, like, hi, how are you? Here's my interview. Yeah, don't do that. Leave the gum. All right. Just make sure you brush your teeth. Then you don't need the gum to freshen your breath, right? Make eye contact. Answer questions clearly and completely. Use complete sentences. So you don't want to use slang, curse words, or inappropriate. Don't exaggerate your accomplishments and appear relaxed and confident. So remember, a job description can be a long, complex form, and you should read it before you sign it. Ask questions if you do not understand anything in the job description, okay? You always want to read that job description because you want to make sure that job description is within your scope of practice, okay? So when should a nursing assistant not perform a procedure, right? If it's out of your scope of practice, not listed in the job description or listed in care plans, you shouldn't be doing it, okay? If you haven't been trained, if you've forgotten how to do all or part of it, please don't YouTube it, okay? All right, have somebody go in with you, do it together so you can practice and remember. If you believe a procedure is not appropriate for a resident, confer with the nurse. So there are common state requirements for nursing assistant certification. Certain time frame to take the state test. For the Massachusetts nursing assistant, you have 1 year. 1 year after you pass this course to take the test to become certified, okay? If you do not take the written and skilled test within the year after passing this course, you would have to retake the training course, okay? You have to work for pay during the next 24 months or 2 years. So every 2 years, you have to go to renew your certification. They're going to want CEUs, continuing education credits. You have 12 hours of that you're needed. Most of the time when you're working full-time, your employer will give those to you. And they're like articles and questions you answer, and you submit them to the employment human resources, and they'll take care of that for you. All right. Usually you have 3 chances to pass the test. Okay, so only 3 chances, or then you're going to need new training course. And nurses must keep certification current. So they usually give it to you in the mail every 2 years. Hey, it's due to renew. You pay for it. Okay. They'll ask you, have you done your CEUs? You'll say, yep. If you've been working, yep. It's only going to be if you get audited, you have to show proof. Okay. Proof that you've done those CEUs, proof that you've been working. Okay. When you go and look up the registry, state registries for CNAs, you can look up mine as well, RN. My name's going to be there, okay? Not social security number, date of birth, maybe address, or at least town you live in, okay? You're going to have the date when it went in the registry, okay? You're going to have expiration date, and it'll be listed any information about investigations or hearings against your license. So remember, nursing assistants must have 12 hours of continuing education credits every year, and that's required by OBRA. Remember, we said OBRA set those standards for what education for nursing assistants should be. So remember, employee evaluations are going to include constructive feedback. It may involve both positive and negative, but if it is not, it should be done in a non-aggressive way. Constructive feedback should be given in a private setting, and it should be work-related. It should not include personal attacks, okay? It's just meant to help you improve, to become a better CNA, okay? Hostile criticism's angry and negative, okay? We want constructive feedback. We want to get better. So here are some ways that we can make constructive feedback beneficial. We want to be open to suggestions. Listen without becoming angry. Consider how to address or fix the problem. And then if you don't know, ask them for suggestions. So remember, evaluations are often the basis for advancement and salary increases. All right, so usually every year you're getting reviewed. Okay, so you want to do well because you usually get, pennies on the dime, but you should at least get a little bit of a raise, right? So why is it important to be open to feedback and to use suggestions for improvement to get better at our jobs, right? We're human. We want to get better. We're not perfect. Okay, feedback's going to help us improve, get better, and grow in our field. So we want to remember these points about conflict resolution. Before reacting, think about reasons someone's behaving in an undesirable way. Be reasonable with your requests. Think about how to solve the problem, how the best way to do it. Know when to be firm and know when to walk away. And also know when to compromise. So a lot of times alcoholics will go to Alcoholics Anonymous and they have a prayer. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. All right. So for those of you that are not religious, that don't follow God, just take that out of it and say, please help me. All right. But that will kind of help you to knowing those differences. So have you ever had conflict with a coworker, boss, or customer or client, or with a teacher or another student? How did you resolve that conflict? What worked? Did you have to go up the chain of command? So remember, many things, both personal and professional, are going to cause stress. Stress happens because of a stressor, and anything, even positive things like a new job, new baby, can be very much a stressor. Okay. So examples of negative situations that can cause stress, right? Negative situations, a death in the family, a loss of finances, a totaling of the car can cause stress, but also positive situations, right? Having a baby, starting a new job, getting your first house. So I just want to emphasize any change in the environment, routine, life circumstances can be mentally and emotionally disruptive, even if it's a positive change. So there are certain types of behaviors that are common for you when you're stressed. Is it easier for you to recognize when you're stressed? So signs of unrelieved stress and burnout. You might witness these in other people, but it's always something you want to bring to light. If they start arguing frequently, losing patience, being angry, wanting too much control, obsessing over small, unimportant things, being rude, irritated, or frustrated, or having trouble focusing on resonance and procedures, okay? That's evidence of caregiver burnout. These people really got to take a vacation, right? Reset themselves. Or maybe it's time to not stay in healthcare anymore. I have seen that before, right? But that's why you always prioritize yourself so you can be the best caregiver possible for your residents. So think, how do you manage stress? What helps you feel better? Do you like to go on walks, exercise, sleep? Are you getting enough sleep? Eating healthy? Do you abstain from smoking and illegal drugs? Are you focusing on one task at a time? Do you have a hobby you enjoy? Social situations, friends to meet up with? Do you have counseling services, right? Can you set realistic goals for yourself to help you manage your stress? And then my favorite personal one, use a personal reward system. So something I will ask all of you to do once you finish this course, wasn't easy, right? That was a big old workbook I gave you for homework because I'm a big meanie, okay? Reward yourself. When you pass your midterm and you pass your final and you make it through this course, I want you to think of one thing that you're going to reward yourself with. All right. Maybe your financial needs, it can't be something big. Maybe it's just going to be getting an extra dessert. Maybe it's going to be going out with your friends. Okay. Maybe it's going to be buying that one little thing online you've been putting off, but do something nice for yourself. Okay. Just for you as a good job. You did this. It wasn't easy. This was an accelerated 4-week class that hit you hard. 28 chapters, right? That's not easy. So be good to yourself. You've earned it. You've earned it. So remember, setting goals can help manage stress. The key is to make the goals reachable. You don't want to set only long-term goals, but do short-term, reachable goals that you can meet in a reasonable time frame. Okay. So think, what short-term and long-term goals have you set for yourself? So I'll be honest, my shorter term goal probably next year, I'm going back to school. I'm going to be working on my bachelor's. Okay. My long-term goal, what I would love if I could see myself in 10 years is I would love to open my own assisted living facility and run it the way I want, with a focus being on reduced medication, delicious food. So if somebody needed vitamin D, B in their diet, more fish oil, that we add that into their food, that I have a chef and a registered dietitian, that I have a garden growing all my own fruits and vegetables. So really good food and entertainment, things to entertain people and to also make them feel like they give back to the community. So maybe opening a thrift store where we could donate money. We could have adopt a grandparent. We could go do that. But that's always been my long-term goal, is I want to change the way people age. And I want to start facilities that focus more on quality than quantity, right? And helping elderly people feel like they have a legacy and still an impact in society. So those are mine. Think about what you want yours to be. Where are you going to go in healthcare? What do you want to do? Do you want to change things? You can. It's up to you. So what do you think your favorite part of your new job will be? Paycheck helps, right? But what else? Maybe forming the relationships, making a difference in people's lives. You matter. This isn't just a pushing paperwork. You matter to these people. You care for them. You make a difference every day you show up. So you have now reached the end of your nursing assistant course. Very soon, you'll be a practicing nursing assistant. Remember what you've accomplished and know the importance of the work you have chosen to do. You are going to be a valuable member of a care team, a team that literally saves lives every day. It's a very, very notable profession, noble, and one that provides a tremendous service. I can't do anything without my CNAs. You are the backbone of care. You are more essential than all of us are, right? If your patients are medically stable, nurses and doctors could disappear for an hour and it wouldn't matter, but the CNAs, vital, okay? You'll never get paid enough for the work you do, but I cannot thank you all enough for taking this course and being part of the future in healthcare and taking the time to care, to practice empathy, and to make a difference. It's why I did this. It's why I became a teacher. So remember, as you move forward in your new profession, never stop learning. Learn new things every day. And that was your last chapter. I want to thank you all for the time you took in listening to me dribble on in all of our lectures, and for taking the time to really come here and care and enter this noble profession that I love so much. I can't wait to see you all once again on our graduation day. All right. And don't mind me. I am a sappy one. I'm probably going to be crying because I'm proud of you all and giving out numerous hugs. Forewarn me now if you don't want an incoming Carrie Ann hug. Okay. But I love you guys. Have a great night, and I'll see you soon.